anybody who did not get the pre-test, raise of hands. Everybody got? You did not get?
We have, it's also on the WhatsApp group, POGS Foxy group.
No,
And POGS friends के ऊपर भी link डाल दिया है. Madam ने डाल दिया.
Thank you so much. So madam has put it on the society's link. Thank you, madam.
So a few of them don't have internet, so
Okay.
they're not able to scan.
Doesn't matter. We are not missing on so much. So you can just do it with your neighbor. The person sitting next to you, you can do the pre-test. So we wait for another minute and then we start with the... Yeah. How many of you finished? Yeah, so quite a few have finished. So 30 seconds more. So somebody please guide me, you finished? We can start? Yes. So, yeah. So what is eclampsia? Eclampsia is a new onset generalized clonic seizures or coma in a patient with preeclampsia typically. HELP syndrome can also be there. There can be atypical eclampsia and there can be associated seizures even with gestational hypertension. Now the magnitude of the problem, if you see in our country, it's been found that about 2% of all pregnancies as per the National Eclampsia Registry would have eclampsia. And nearly about 4,94,000 cases of eclampsia annually are documented in the entire country. There may be many more which are not actually documented, and therefore we have a very large task at hand. And what we have to remember is typically the hypertension in pregnancy definition, wherein we call off any proteinuric hypertension which occurs after 20 weeks of gestation is typically called as preeclampsia. Before 20 weeks of gestation, if there is hypertension, then it's called as chronic hypertension. And you have to also remember about the new entity that has come up, and that is very important, that even after delivery, a woman will have hypertension which may last any time from 4 weeks to even month or maybe lifetime. And there can be a new appearance of hypertension post-delivery. So these definitions are very clear. We are not going to place much stress on that, but we'll definitely remember preeclampsia is that condition which is proteinuric hypertension in women beyond 20 weeks of gestation, where there will be liver function tests which will be 2 times than the normal, that will be upper limit. There may be any other severe features in the form of pulmonary edema or any kind of an neurological association. And these are the ones in whom eclamptic seizures will definitely occur. And eclampsia, therefore, is something which is a part of preeclampsia with severe features. Now, what we have to remember that it's an iceberg phenomenon, because when we look at the blood pressure of 140/90, there is a whole lot of problems that are under this surface. There can be a woman who can have problems, underlying problems which require to be investigated, and the babies of preeclamptic mothers definitely suffer. So the moment in your practice you get 140/90 blood pressure, you must think of this iceberg always in your mind and start investigating this patient, because if you look at the futility of eclampsia, despite there being advances in detection and management, eclampsia remains a common cause of maternal morbidity and death, especially in resource-limited regions. And today I am in Patna, in that part of the country where Buddha is really yugolized in a large way. And therefore, when we talk of futility, we talk of futility of ego. A man asked Lord Buddha, I want happiness. Buddha said, remove your I, that's ego. Then remove want, that's desire. And see, now you are left with only happiness. And eclampsia really takes away your ego. And it also takes away your desire sometimes, because if there are complications, you may feel that, no, I am not going to do any obstetrics anymore. And this has to be remembered. So quickly looking at the pathology as to why do seizures occur in preeclampsia or hypertensive disorders, we have been believing all these days that it is because of cerebral vasospasm and cerebral edema. Yes, that is one of the causes, but there is also some sort of a placentoneurological action, which is because of the inflammatory cytokines released from the ischemic placenta, which cause a lot of excitatory neuronal receptor actions in the brain, which can give rise to eclampsia. We are very well versed with the genetic predisposition and the environmental exposures which finally go to give this particular problem. You can see in the first part of that picture, The normal placenta is wonderfully perfused, while you can see in the lower part that at the time when the placenta is forming in the first trimester itself, there is constriction of the spiral arterioles, and this placenta is suffering from hypoxia from the onset. And that means whenever you get that 140/90 BP, please be on guard, because this abnormal placentation is going to give rise to a lot of challenges, immunological inflammatory cytokines in the body, which will increase the systemic venous return in the cerebral vasculature, vasospasm, cerebral edema, and symptoms of eclampsia like seizures. So why is there eclampsia? There are changes in the neurosteroids, there is inflammation and infection, and there is blood-brain barrier disruption, because autoregulation of the blood pressure during pregnancy is also altered. And therefore, women are very highly susceptible to undergo seizures, even with the slightest change in the blood pressure. And therefore, this has to be remembered whenever we are looking at this condition. And it has to be learned, and therefore I want to congratulate Pragya for keeping this particular drill here, because we all have to be well versed with the fact that eclampsia doesn't have only now short-term consequences, but the woman will have long-term residual consequences, which will last, maybe giving rise to dementia, so many other ischemic and hemorrhagic stroke and injury to her brain, and therefore we have to by all means try to prevent these complications. So whenever we look at the cerebral CNS complications in association with hypertension, infarct, cerebral edema, PRES, and blindness can also be underlying whenever we are looking at seizures, and therefore we have to be always, you should not consider eclampsia, magnesium sulfate diya baat khatam. There may be so many other things underlying which also we have to remember. And this is typically what is called as posterior reversible encephalopathy syndrome, present in nearly all, universally all patients of eclampsia. And therefore it is so common that many a times it is a reversible eclampsia. We do not ask every patient to undergo an MRI. And you can see that there are typical hypodensity seen there in that particular area of the brain, especially in the parieto-occipital lobes, which are typically seen in association with eclampsia. And this is because of probably an ischemia of the brain tissue. Posterior circulation of the woman's brain is probably more susceptible because there is less sympathetic innervation there. And many times the treatment is to quickly treat the seizures, try to regularize her blood pressure, and you will be able to reverse this. Now, risk factors of preeclampsia are very well known to us, and we all see that many times women who are primigravidas, who are coming from the Asian ethnicity, or we are older in age, with multifactorial gestation, lack of prenatal care are the risks. And there are several signs and symptoms which may precede eclampsia, such as visual disturbances, epigastric pain, severe persistent occipital or frontal headaches, headache being the most commonest in presentation, visual disturbances the second commonest, and right upper quadrant pain or epigastric pain can be common. Now, if you look at the incidence and the occurrence of eclampsia, antepartum is the most common type, which is 38 to 53%. But even in labor, women can have eclampsia, about 18 to 36%, and postpartum, 11 to 44%. Atypical eclampsia can occur even in patients who are less than 20 weeks, and convulsions despite adequate magnesium sulfate can be there, and even after delivery, women may have convulsions. Now, another entity, and I'm sure you all are dealing with this in your practices, with women now choosing to become pregnant later, lot of obesity. Many women also have chronic hypertension. And this chronic hypertension gives rise to certain Charcot-Bouchard-like aneurysms in the brain, which are microaneurysms. And these are typically seen in the deep penetrating arteries. Immediately there is a rise in the systolic blood pressure. A patient can have stroke, and she can have intracerebral hemorrhage. And this also has to be differentiated from eclampsia, or whenever there is seizure, we have to also try and find out whether anything is there. Now, there is a good news, and I would like you to pay a little attention, because I'm going to come up with some videos which have been recorded by my students for this particular drill. And if you pay attention, you'll be able to take more benefit from this particular drill. So the good news is eclampsia may be considered a very preventable disease in many of the cases. But, and the reason being the MACPI trial. And this was a publication which happened in the Lancet. And it showed that magnesium sulfate reduced the risk of recurrent seizures in epileptic women by 52% when compared to diazepam and by 67% when compared to phenytoin. And not only that, it was found to be an effective panacea for treatment and prevention of magnesium sulfate. And at this point in time, when we are standing in our practice today, magnesium sulfate is not only used for the treatment of eclampsia, but it is also used for preventing seizures in women with severe preeclampsia. It's also used as a tocolytic to slow down labor. And it is also used to protect the baby's brains, especially when they are premature babies. You can give it for neuroprotection. So now let's look at a clinical situation, and we all know that eclampsia can occur anytime. I'm sure that all of you have your delicate bags, and in those delicate bags there must be some piece of paper. And there are some questions which may come to your mind. I would request you to write your questions, so at the end of this session we'll have some question answer session where the questions which you have been asked we'll be able to deal with. So you can please write those questions whenever they come to your mind on the paper, and so that we can continue this drill. Now you can see here that this is Ina, who has come with a husband, a 32-year-old primi gravida. She has history of PCOS and she has conceived with ovulation induction. We can see the risk factors of preeclampsia are typically there. And till now, when she was 33 weeks pregnant, she has had an uneventful course. I hope the volume is on. Volume for my laptop is on. 10 times तो बोला था मैंने. नहीं, मेरी आवाज नहीं मैडम, ये लैपटॉप की आवाज. I want the volume here. Nikhil, no volume. तो फिर ये मुझे सुनना नहीं है ना. I have heard this. एक मिनट. सी मेरी बहुत टनटनी आवाज आ रही है, ये नहीं लग रहा है इधर. It is playing, but the voice has to come, na, my dear. माइक ऐसे थोड़ी ना इसके ऊपर सिर्फ
आ गया ना. आया
नहीं. अभी तो यहाँ का भी चला गया. They take away the fun of your entire work. Hi, hello.
फुल बड़ा हुआ है. ये देख वॉल्यूम भी फुल है. फुल है वॉल्यूम. एक सेकंड.
हेडफोन्स क्यों लगाए किसने?
एक सेकंड. इसका रीड ही नहीं. एक सेकंड. थोड़ा सा वॉल्यूम वहाँ से बढ़ाइए.
Are you able to hear? Are you able to hear? At the back? Are you able to hear? See, there is somebody saying no. So I actually am very sorry for this, because from my level, whatever care should have been taken, I have taken, but then probably they have not been able to give us that provision. But you can see that this is a situation where Ina has been brought by her husband to the OPD now, and she's been telling the doctor that I am having a lot of headache and not feeling well. I feel like vomiting and I don't feel like eating food. And then she says that, is there any other problem? Have you been having hypertension? She says no. And then she tells her assistant that immediately take her blood pressure. And the assistants, you can see that the blood pressure is being taken correctly with a sitting position, with the correct arm size, and then the blood pressure is recorded as 170 by 100. Immediately the doctor says, come on, let us make her lie down because her BP is very high and we need to see what she requires to be done. And immediately she takes her to lie down. So always be on guard whenever there is headache, epigastric pain, nausea, especially in the second trimester, vomiting. Patient is not feeling ill and sick. And you can see that she was taken on the bed and immediately she started going into a convulsion. And as it would be, the OPD did have a magnesium sulfate box, and that is something which we practice in our hospital. Everywhere where a woman is, we always have a magnesium sulfate box available. And here the junior is saying, I cannot give her IV, I cannot tie anything. So what should I do? The consultant says, give 4 grams magnesium sulfate intramuscular. So in such a situation, if you are not able to give a loading dose IV of magnesium sulfate, you can give intramuscular 4 grams of magnesium sulfate immediately, and that can help completely stop that conversion. Please don't go and give a diazepam, because diazepam causes both distress for the mother as well as the baby. So the first drug you can immediately give a magnesium sulfate, and always remember the dose. 1 ampule of 50% of magnesium sulfate contains 1 gram. So if that is so, how many ampules we'll have to give for 4 grams? Everybody, yes, 4 grams of ampules will have to be given, and that is what happened. So you have to have a rapid nursing response team available, and you can see that typically the patient has to be changed on one side, and this action has to be there, because otherwise the woman will aspirate and she will have to extend her neck so that we can not allow her tongue to fall back as well as her tongue bite to happen. So this is typically the loading dose of magnesium sulfate, where you give 4 grams of magnesium sulfate in 20 ml of solution over 10 to 15 minutes. And you can do it simply, even if you feel that you are lack of hands. Nowadays we have the 100 ml NS which is available. So you can just put the 4 ampules in the NS and let it run through an IV to the mother, so that you don't have to monitor it, and it can be delivered between 5 to 6 minutes, so that you are free to do something else. So magnesium sulfate loading dose is something that we all have to always train ourselves, our paraphernalia, our staff, and it should be always available in a box everywhere wherever the pregnant mother is likely to go. So these are the contents of the magnesium sulfate box. 10 ampules of 50%, that is 1 gram per ampule. Water for injection, you can have normal saline 100 ml. Intracath 20 gauge IV set, because 20 gauge is very easy to apply. Sticking plaster, syringe 20 ml, 1 of 10 ml, or you can have a 10 ml or a 20 ml. It's always better to have a 20 ml one and a 10 ml one. A mouth gag or an airway, and alcohol swabs and gloves number 6 or 7, whatever 7 are usually universal, so that everybody can wear them. So always be ready with magnesium sulfate box, easily accessible, and you can also put the dose sheet inside the magnesium sulfate box so that you can quickly read how to give this dose, and you can give it so that in a hush you don't make mistakes, and always be ready. And always remember that magnesium sulfate more than halves the risk of eclampsia and reduces the risk of maternal death. It is substantially more effective than diazepam, and it is substantially more effective than phenytoin. It causes blockade of the NMDA receptors, reduced presynaptic release of neurotransmitter glutamate, potentiation of adenosine action, improved mitochondrial calcium buffering, and blockage of calcium entry via voltage gated channels. Now this is another very important checklist that you have to have. Now you have this woman who had a blood pressure of 170 by 100. Now you saw that she threw a convulsion. But you may have a patient coming to you who is just having hypertension, but she may not throw a convulsion yet. So this is the time when you will be triggering this particular checklist. Usually the first initiation of this checklist is when the blood pressure is more than 160 or 110. You can tweak it a little in our patients where you can even trigger it at 150 to 100, because most of our pregnant moms have a blood pressure of 100 by 70 during their regular antenatal period. So even at 150, 100, if she's showing any severe features, that is the time when you can initiate this particular severe hypertension checklist. And what does it say? First, initiate the magnesium sulfate. 4 to 6 grams can be given in 100 ml solution over 20 minutes. Or you can put it in an infusion pump. I'm going to demonstrate that also to you. Label the pump. Or you can give it an intramuscular injection, or the classical one which we have been giving in the 20 ml solution. Always give antihypertensive medications to this woman immediately. So what is your choice of antihypertensive? Is it labetalol or nifedipine? Labetalol, raise of hands. Everybody labetalol. Anybody for nifedipine? Nobody for nifedipine. Okay, and we need to have both, absolutely. Yes, so we'll be coming to where we should have both. But friends, when you are in the OPD, you don't have an access to IV, you can just place a 200 milligrams of labetalol and make her swallow it immediately. Because even the 200 milligram tablet has an instant action. So you can immediately give her that 200 milligrams by the time the magnesium sulfate is going, and then you can consider maybe giving her the rest of the things. So you would be repeating her blood pressure measurement every 10 minutes during administration. Hydralazine also has been mentioned here, but it's not very easily available in our country, and now there are a lot of issues associated with hydralazine, so it's not recommended either. And if any of these first agents, as Dr. Mitra said, that sometimes the BP may not just respond, then you would recommend an emergency consultation with a specialist and call for help, because then we require to step up or use it in combination. So you can see here that this is a patient of severe hypertension. Again, we'll, आवाज है अभी? No chance? Okay.
Nausea or vomiting anytime, then report to the hospital urgently. Yes, doctor, I'm having headache right now. Get the BP app. Oh, she's having somebody bring the eclampsia box. You have to put this injection in this for 4 gram loading dose. And then I will start her with 1 gram per hour loose band every. Yes. How are you, Priyanka?
So what is the video trying to tell here? I'm sorry for the miscommunication and the overlapping sounds. But here the patient is being kept for antenatal checkup, and they found that her blood pressure was very high that day. And then she asked the consultant, should I give her magnesium sulfate? And she said, yes, give her the loading dose. And then she asked her, should you now deliver this patient after we have given the loading dose of magnesium sulfate? So the answer to this question is no. She said we can wait, we can stabilize her, and if the baby is premature, we can continue to wait till 34 weeks of gestation. But however, if there is severe preeclampsia, you would definitely deliver her by 34 weeks of gestation. But the fact that you have given a prophylactic magnesium sulfate for severe hypertension doesn't equate to delivery of a patient. While all eclampsias have to be delivered. You understand? However, a severe preeclampsia Just because you've given magnesium sulfate does not mandate a delivery. You can stabilize her, reduce her blood pressure, buy some time for her baby to become mature. Even sometimes she may be anemic, she may be having certain issues. You can give antenatal steroids and then take her for whatever course of delivery that you are going to give her. So be on guard, as I mentioned about help alerts, any vomiting, patient can rapidly deteriorate after initial symptoms, and early diagnosis gives the best chance. And whenever a patient comes to you in abdominal pain, many times we consider it is hysteria, it is gastritis, she is not eating properly, or it is because of her iron calcium or some starvation or outside food. It may not be all this. It may be a stretch on her Gleason's capsule, and it can be a right upper quadrant pain. So be very, very empathetically looking at this, because there have been many mishaps where patients have been given antacids, have been sent home, and they have come back in stroke, convulsions, unconscious, or dead. So all of these have to be remembered whenever a patient comes to you in pain in abdomen during the second part of a pregnancy. So eclampsia always is an hypertensive emergency. It's not an hypertensive urgency, because here the end organs are damaged, and it usually occurs at a raised blood pressure. That's easier, but sometimes it can even occur in a normotensive woman. Now, we were talking about drugs for urgent control. Labetalol intravenously is something that we can give, but nifedipine has been our friendly drug for a long time, where we give it 10 to 30 milligrams per orally and repeat it in 30 minutes. However, if the patient has tachycardia, then you will have to consider using labetalol. If the patient has bradycardia, then you are safe to give nifedipine. So use the 100 pulse rate as your cutoff for using any of the two. And even oral labetalol, 200 milligrams, it's an Indian study which has shown that it is as effective, and then you can start the IV line. Now, what is to be remembered about nifedipine, however, is always better to give it as a slow release formulation, because it can have an erratic absorption, and never ever give it sublingually, because there can be sudden hypotension which can kill both the mother and the baby. And this is a typical chart which you can keep in your mind when you're talking of labetalol dose: 20, 20, 40. After 10 minutes you do the blood pressure, and the maximum dose that you can give is about 220 to 300 milligrams, and that can gradually titrating labetalol dose can help you in giving a better blood pressure control to this patient. So this is another algorithm. I have taken a pre-test. I'm also going to take your post-test, and if any one of you wants this presentation, I will give it to you. I'll send it the PDF to you. You have to just send a request to me, either on my phone or my mail. That mail is there in the pre-test. Because you've attempted it, you have it. And or you can ask Bhumija, and I can put it in your Patna group also. So your entire Patna society can have the PDF, so that you have all these tables at handy. So labetalol and nifedipine dosages with titration against blood pressure record. Now, why don't we give hydralazine? Because it is known to cause certain adverse effects, especially symptoms which are signs which are similar to HELLP. There can be maternal hypotension, fetal heart deceleration, and there is also a possible increased tendency to serious ventricular arrhythmias compared with labetalol in women with eclampsia. Now you can see here that Ina has been brought, this is another Ina, been brought in the hospital. So what we are trying to depict from this particular experience is that a patient coming pregnant with seizures, unconscious, is always eclampsia. That has to be your first diagnosis. And you are safe in giving her magnesium sulfate. Epilepsy, cerebral malacia, meningitis or encephalitis, or tetanus also can be the differentials. But always the primary diagnosis is eclampsia, even in an unconscious mother. So these are the various DDs that you have to keep in mind if you find that there is a little different than usual presentation of eclampsia. Now I want you to participate and ask some, answer these questions. So you can see here, now this is a video recording of a woman in eclampsia. I put the sound down, but at the end there was all the sound of her secretions which were coming. So which phase of eclampsia was this? The convulsing phase. So we were justified in putting the airway. Position of the patient? Wrong. Then what else should have been done? Suction, oxygen. Then side rails, put her on the side. Then, yeah, that will happen. But right now, immediate rapid nursing care क्या होना चाहिए था? Where is the respectful maternal care? So she had to be covered. There had to be somebody by her, restraining her, holding her, guiding her. So she was just left to convulse to herself. And these usually can happen. So you have to be remembering that all these things, the typical ABCD, doesn't stop even in eclampsia. It's not that the convulsion will go off, but you should do all attempts to try to abort that convulsion and try to give her as much care, nursing care as you can during that time. Now you can see that sometimes if you are not prompt, and this was a patient who was convulsing at home, and her relatives felt that she is hysteric and she has some badha, na, wo, some bhoot khet ho gaya, shayad. And then look at the amount of macroglossia that she has suffered from. And then after 72 hours after treatment, she had to be given a lateral intubation. And then after 7 days, it reduced. So we have to be very careful that if you don't take care. And the seizure phases are usually a hallmark feature of eclampsia is a new onset tonic-clonic type seizure, which typically lasts around 60 to 75 seconds, followed by a variable lasting post-ictal phase. So the moment there is a seizure, you have to call for help because you need many people to help you. And these are the typical care that you have to take in the patients. So it's a life-threatening emergency. And therefore, there has to be a continuous intensive monitoring and not to be left alone in the darkened room. And there has to be respectful maternal care. So you can see this is a patient who has been placed. This is in one of our centers. This is actually our labor ward. This is not my eclampsia room. We'll be showing your eclampsia room shortly. But this woman threw a convulsion. And immediately in that place itself, she was given a left lateral position. And you can see everything has been brought into her side. The syringe pump where magnesium sulfate has been started. She's been put on a multipara monitor. And then you can see that the NST machine has also started to monitoring the fetal care and she's been nasal oxygen. So these are the ways, and it's a well-lighted room. And this is how the eclampsia room looks. So whenever a patient has come in convulsion, you can see. Again, here you can see that they have not given the correct position. The patient has to be in the left lateral position. And they are taking advantage of the post-ictal phase. Don't get carried away by the post-ictal phase. The patient can still throw a convulsion. And you should be knowing the dosages of giving magnesium sulfate. Now the magnesium sulfate is given typically as a 5 gram in 500 ml of Ringer's lactate. How many of you use the Zuspan regimen here in your patients? Raise of hands. Okay, so how many of you use Pritchard's? All of you use Pritchard's. Yes, because that is the WHO and the Government of India guideline. And the reason why the Pritchard's regimen has been proposed, because it is easy to deliver, it is effective, that has been understood. The Zuspan regimen is found to be cumbersome in monitoring. But I must tell you, in the last 20 years of my practice, we are only using the Zuspan regimen. And you can use it confidently. The reason being, now we have the syringe pumps, we have better monitoring, IV fluids. And sometimes if you have a patient who has thrombocytopenia, the Pritchard's regimen may cause hematomas in the gluteal region, which can cause septic abscesses. So here it's very simple. You just give 5 grams of magnesium sulfate in 500 ml of Ringer's lactate, and the infusion rate is about 100 ml per hour or 1 gram per hour. That is simple by measuring the drop rates, which you can do. But you can also give it through the infusion pump, which I'll show you shortly. Immediately the patient's laboratory has to be taken, and this is to look for HELLP primarily, see whether her renal function tests are affected, what are her platelet counts. Here you must also send her serum electrolytes. So above the preeclampsia lab which you do, you must also do a serum electrolytes for her, and if it's possible, you may consider doing a fundoscopy. So this is how an infusion pump is given now, and again I think we'll have a voice challenge, but I'll explain to you. So what are we trying to show you is in a syringe pump, you just load a 50 ml syringe which contains 5 grams of magnesium sulfate. So that loaded syringe is put into the syringe pump in such a fashion that it is adjusted at a drop rate, at a rate of delivery where 10 ml of that fluid will be delivered to the mother in 1 minute, in 1 hour. So 1 hour she will get 10 ml, so that in 1 hour she will get 1 gram. And that, once the syringe pump has done it, you don't have to keep on seeing whether the fluid, the drops are going properly. It automatically gets delivered, 1. Secondly, it's a concentrated fluid which gets delivered. 3, there is no fluid overload because we are worried about pulmonary edema also in these mothers of eclampsia. So usually in our facility, for neuroprotection when we give, for tocolysis when we give, for prevention of eclampsia and for treatment of eclampsia, all our magnesium sulfate of 24 hours is always delivered by the syringe pump because it is very, very easy to deliver. So whenever there is an eclamptic seizure, guardrail should be up. There has to be a large bore peripheral intravenous line, a syringe. Okay. Done? Finished? To stop or to go on? Continue. So diazepam should not be given to stop or shorten the convulsion. No more than 5 milligrams should be given over 60 seconds. Rapid administration of diazepam may lead to apnea or cardiac arrest or both. New convulsion, a padded tongue blade should be inserted between the patient's teeth. Avoid stimulating the gag reflex. Whenever you're putting the airway, don't put it on the backside of the pharynx, otherwise she will vomit and aspirate. Position her on the left side and secretions from her mouth will be sucked, and auscultate the lungs of the woman every time that she has had a convulsion, and that is something which should not be ever forgotten. So this is an eclampsia checklist. It looks very busy here, but as I promised you, it will be coming to your WhatsApp boxes. But it says call for assistance, designate a team leader, checklist reader, primary, then left lateral position, magnesium sulfate, and all those things. Draw your PE labs, administer antihypertensive therapy, develop a delivery plan, and debrief the patient, family, and the obstetric team how to go about it. I think we discussed the maintenance dose of Pritchard's regimen is something that you all know, so we'll not go into detail. But I will also want to tell how many of you are using lignocaine? No. None of you are using. You don't find it necessary. It's very painful otherwise. Yeah, you are using. See, we, especially in some patients, if we have to give a Pritchard's regimen, we will use, we'll use a lignocaine. So you can withdraw 1 ml of 2% of lignocaine and then give a deep injection. Please remember, it has to be a long needle. It has to go deep intramuscular. It has to be intramuscular only. It should not be in the fat. So therefore, these things are very important because, and why? You need a 20 gauge needle at least, because it has a very high specific gravity. Have you ever seen magnesium sulfate when it was broken and fell on your black surface? Did you see? It immediately crystallizes. And therefore, it has a very high specific gravity. And therefore, it has to be given correctly. And it has to be, here it's written 16 bore needle, but I feel it's very cruel to give it through a 16 bore needle because it will definitely cause an injury to that muscle there. So 20 is fairly good enough. And then you have to monitor the patient. Patellar reflex, if it is present, it gives you a green, clean cheat that the action is effective and it is not a toxicity. Respiration is not depressed, that is respiratory rate is more than 16. Urine output during previous 4 hours is exceeding 100 ml, that is 25 ml per hour. Serum monitoring of magnesium sulfate has been advocated, but it is very expensive and not necessary, it's impractical. So you will do only clinical monitoring of this patient. So whenever there is an emergency treatment for eclamptic seizures, 0 to 5 minutes you will be doing the rapid nursing care, then you will deliver the magnesium sulfate, then you will treat her severe hypertension, wait for the labs till they are coming, and then you may consider giving her, if she has a next convulsion, many times your 4-gram loading dose may not be enough. So if she has a second convulsion, immediately, you've given the 4-gram, and within 60 seconds, she throws a second convulsion. What are you going to do? 5 gram in each buttock? Yes, you may continue if you are preachers, or you may give 2-gram additional. So you can just give 2-gram additional because the loading dose is 4 to 6 grams. So if you are given only 4 grams, you can consider giving 6 grams. And these numbers have to be in our pit and pat mind. Therapeutic 2 to 4 is the therapeutic level of magnesium sulfate. Feeling of warmth which the patient feels means the level is 3.8 to 5. If she loses tendon reflexes, it is more than 5. Respiratory depression more than 6. Respiratory arrest occurs after the magnesium sulfate level becomes more than 6 millimoles per liter. And if it is more than 12, she can have cardiac arrest. So you are not going to wait till that. What is your determining barrier? Where? The patellar reflex, best. So that is where you have to understand. So if the patellar reflex is absent, what do you do? Yes? No, she will throw a convulsion, no? Just withhold the further dose of magnesium sulfate. Don't immediately rush for the calcium gluconate. See whether her respiration is depressed or not. And after a while, you can restart the magnesium sulfate again. I think this was a video which we have placed at the wrong place. But this is just showing you the same patient, the video recording. Typical rapid nursing action and everything in place. Now, how many of you use the Muse chart? Only one hand going up. Nobody in Patna uses the Muse chart. The maternal early warning signs chart. No? No, from today we will start using it. Now, this is a modified MOEWS chart which helps us in assessing things. So you can see what all can be assessed. Awareness, headache, vision, systolic blood pressure, diastolic blood pressure, respiration, O2 saturation, pain in the abdomen and chest, fetal signs, urine output, proteinuria, platelets, and magnesium sulfate. Monitoring signs. So you can see that this chart has colors. So you should get a printed chart which has colors, the green, yellow, and the red. And you can just tell your nursing staff or assistants, the moment things are in green, they are all fine. But if they start going in yellow, we have to be surveilling her closely. The moment they go into red, you require to call for help. So these are the typical charts. This is called as a preeclampsia early recognition tool. Here it's the same modification of the MOEWS charts, and these are very handy charts which you can use in your day-to-day practice. Now, if the convulsions occur after 15 minutes, what do you do? 2 grams of magnesium sulfate, or as madam said, she will give the full loading dose of Pritchard's, 5 grams in each buttock, and wait and watch and give her a nursing care. How many of you use lorazepam as your first choice of anticonvulsant? Levetiracetam, Levera, any of your, they will add it, yeah. Yeah. So usually the first drug of choice in an emergency casualty would be a Levera, which will be given. But sometimes we may have to, if the patient is not responding to magnesium sulfate, we all should be aware of lorazepam, phenytoin dosages. So we can give it till the physician comes in place, but usually we are lucky now that we have people around who can help us with this. We have to remember that phenytoin is not a very preferred dose because it may cause hypotension and cardiac arrhythmias. So either it will be Levera or lorazepam that will be given. Mild side effects are known with magnesium sulfate and we all are experienced in those. Now when there is respiratory depression, that is the time when you will stop the magnesium therapy, give the calcium gluconate, give oxygen by mask, maintain airway and definitely keep her in the recommend position. If there is respiratory arrest, all this in addition, you will intubate the patient. The patient has to be intubated and ventilated, and the ventilation should be continued until the resumption of normal spontaneous respiration occurs. Now, if the urine output is less than 100 ml in 4 hours and there are no signs of magnesium toxicity, the next intramuscular dose of magnesium sulfate can be reduced to 2.5 grams instead of 5 grams. Or the next IV dose which we give, which is given the drip which is going, can be slowed down a little so that half of the dose will be delivered. And particular attention should be paid to fluid balance because nowadays we are seeing that many times we cause a lot of fluid restriction, and because of that fluid restriction sometimes they are dehydrated rather than overhydrated. Do a careful maternal and fetal monitoring and look at the baseline labs. Fetal monitoring can be done by the electronic fetal monitor. And during a convulsion, the baby will show a little bradycardia, but it will revert back again after the mother is oxygenated. So bradycardia during convulsion is not an indication for an emergency cesarean section. And you have to do risk stratification looking at all the severe signs that are there, and accordingly your treatment plan will be individualized. Monitor the change of the status once the patient is stabilized. Consider seizure prophylaxis, continuation, chronic hypertension. And special delivery decisions will be dependent on the mother's condition and the baby's condition. And in premature babies, do not forget to give antenatal corticosteroids. Contraindications to delay in delivery are uncontrolled hypertension, pulmonary edema, eclampsia, abruption, DIC, non-assuring fetal status, and intrauterine death. Invasive hemodynamic monitoring may not be always necessary, but if there is a complication, then you may have to consider giving her invasive monitoring. And always remember the dose for fluid management as 80 ml per hour or 1 ml per kg per hour should be your delivery dose of the fluids, and always prefer crystalloids than colloids in this patient. And remember that oliguria is quite common and less than 15 ml per hour and usually does not need any fluid resuscitation. Because here women are very easily bound to go into pulmonary edema because of fragile capillaries and increase in the low plasma oncotic pressure due to protein loss. Hepatic complications are quite common like jaundice and liver hepatoma, and pulmonary edema, ARDS and pleural effusion have to be differentiated and clinically analyzed. And sometimes if you have given her massive blood transfusions, the patient can also have TRALI, that is transfusion related acute lung injuries. Cardiomyopathy are a reality. Patients do have myocardial infarction and arrest, and therefore sudden BP drop down, sudden magnesium sulfate, all these medications should be carefully given. And always remember the typical drugs that we give, antihypertensive use may cause sudden maternal hypotension and placental abruption, especially with nifedipine. Fluid overload and beta mimetics will cause pulmonary edema. Diuretics can cause pancreatitis, especially in patients with ARF. And sublingual nifedipine can lead to myocardial infarction and hence not to be used. Keep this patient under close postpartum surveillance. And you can see here that this patient is delivered and now ready to go home. You can see that she is not looking happy at all, the patient. She's saying, I'm having headache right now. And she immediately throws a convulsion. So even after post-delivery, she can have a convulsion. Now, in the last 2 minutes, we'll just discuss this Ishani, who is a 32-year-old woman who is presented 4-day postpartum with hypertension and severe headache, and she was found to have severe preeclampsia. So what would be your first action? Yes, you'll give her magnesium sulfate and you'll also get her imaging done. Her imaging was done and it showed that she had intracerebral hemorrhage in a postpartum woman with preeclampsia is a commonality because it is a puerperium is a thrombotic phase nearly for the first 5 to 6 weeks, and you can see that there is diffuse vasospasm seen on cerebral angiograph and there is a hemorrhage, and then there can also be signs suggestive of press. A brain biopsy was done for this patient. There was no evidence of vasculitis and she was diagnosed with press because of the vasoconstriction syndrome. So do you feel that eclampsia can be prevented? All of you feel? Yes, it can be prevented. So you can use a ready reckoner. This is the Gestosis India chapter which has come up with this Gestosis score. So this is a simple score which you can apply to your antenatal mothers and then decide that they require close surveillance or maybe a closer surveillance, more investigations. And that can help you in preventing preeclampsia and its consequence eclampsia. Always be very sensitive to the symptoms and also educate your patients and your family about them. Always be on guard in your eclampsia room should be well equipped. There has to be oxygen, all the new resuscitative facilities, protocols, documentation. You can see the nurse here is updating and you can have this eclampsia list here, which is, with the dates. Checklisting is done at the beginning of every week so that you are well armed with the contents of that box. And this is the National Eclampsia Registry. Any one of you wants to become a reporter, please send me a hi. I can send it to you. And thank you so much for giving me a patient hearing. Post-test. There is a post-test also which you can all take. Post-test. Any questions? Bhumija, any questions on the chit? Anybody has any questions? Any questions? Everybody is busy with the post-test. Anybody has any questions?
When I shifted to Patna, I got a shock seeing the Pritchard register.
Yes, yes.
Often confuse birth asphyxia with fetal hypoxia. They are entirely different things. Birth asphyxia is the failure of neonate to start regular respiration within 1 minute of birth, preceded by hypoxia in utero. So many a times the hypoxia may be transient, and after the delivery the baby is all right. So it is important. So, as I've already told, that fetal distress is not to be used, and non-reassuring fetal status is a clinical predictor of fetal well-being. But the point to be noted is that it is also just an indicator of underlying permanent or temporary hypoxia. And it is reported in around 20% of labors, and so the incidence of instrumental and operative deliveries increase. So before labeling a case as a non-reassuring fetal status, we should be very sure before delivering the baby in an urgent situation. So why does or when does the fetal status becomes non-reassuring? Many times there are high-risk factors in the mother, like maternal cardiovascular disease, anemia, diabetes, hypertension, infection, or sudden placental abruption, or the fetus itself is growth restricted, or there is cord compression. So now, the most important thing is that, is fetal hypoxia always ominous? So if we have a NST tracing saying that showing deceleration, so is it always ominous? So it is not so. If the hypoxic episode is transient, then the fetal compensatory mechanisms act, and the fetus response to hypoxia is very good. But if the hypoxic situation lasts for a longer time, then only it leads to tissue hypoxia or metabolic acidosis, and which may lead to cell death or organ failure in the fetus, and finally death of the fetus in utero. So what are the fetal compensatory mechanisms to hypoxia? The most important is bradycardia. And then there will be less fetal movement, and there will be sparing, that is brain sparing effect, means the blood circulation to the vital organs like brain and adrenal glands will increase. And the long-term complications of hypoxia will be manifested in the postpartum period in the form of neonatal seizures or encephalopathy or delay in neurodevelopmental growth. So how to assess intrapartum fetal status? Now, fetal heart rate monitoring is the real-time analysis of fetal status, and both CTG and intermittent auscultation have found to be equally good. In fact, there is no difference in the various RCTs done to show that CTG is better than intermittent auscultation. CTG is available in only high resource settings, and in high risk patients we should definitely go for CTG, but in low resource setting, because it requires less equipments, intermittent auscultation is equally good. Other methods like Doppler sonography or fetal blood sampling may not be available everywhere, and the only objective marker of fetal status is after delivery. If the umbilical cord blood sampling is done and the pH is less than 7, then only we can definitely say that the fetus was hypoxic intrauterine. Otherwise, just going through the NST, nobody can comment. So now coming to the normal CTG tracing, the intervals between the vertical red lines represent 1 minute. So the speed of the paper is very important, and normally it is set for 1 centimeter per minute. And fetal heart rate tracing is displayed in the upper pane and the uterine activity in the lower pane. Now, this is a CTG of a patient primigravida who was in active labor, and this is a reactive CTG showing a baseline of 140 with accelerations, no deceleration, and the patient delivered a healthy baby with Apgar score 9 upon 10. So now, why do we need to, as I've already told, there are certain conditions when the fetal heart rate status means fetal heart becomes abnormal. So, but again, abnormal fetal heart rate has high sensitivity, but low specificity to predict neonatal outcomes. Now, in 1986, FIGO described that we have to assess the fetus according to the heart rate during labor. So the normal, they found that if the baseline heart rate was maintained between 110 to 160 beats per minute, and there was variability with no deceleration, then it was labeled as normal. And if at least one of the characteristics were absent, then it was thought suspicious, and the fetal monitoring was labeled as pathological if the baseline fetal heart rate was less than 100 or more than 160, or there was reduced variability or sinusoidal pattern and repetitive or late or prolonged decelerations or sinusoidal pattern. Now in 1997, the National Institute of Child Health and Human Development in the United States of America, they told that we have to describe the CTG tracing according to category 1, category 2 and category 3. So the disadvantage of this was that they were focusing on deceleration and on CTG. For NICHD, CTG was a must, but the FIGO tells that no, we can go for intermittent auscultation as well. So this classification, the normal, suspicious, pathological, is more in use in low resource settings. So now, this is the pathological, this is sinusoidal wave pattern. This was a patient, she was a multi-gravida with a bad OBS history. She had a abortion in the first trimester, in the first pregnancy, and the second pregnancy, it was IUD at term. So we planned to induce, because she had no other high-risk factors, we induced her at 38 weeks. And then she went into labor, but for 30 minutes, this waveform was there, and so we delivered the fetus, and luckily we could save her, and she went to NICU, but now she has been discharged. So this is the sinusoidal pattern. And this is the saltatory pattern, in which the oscillations are more than, means the variability is more. That is also not good. The variability, if more than 25, that also shows fetal hypoxia. So what is the criteria for non-reassuring fetal heart rate? Major criteria, as I've told, then sinusoidal pattern, sine wave, baseline, amplitude 5 to 15 beats per minute, and frequency 2 to 5 per minute, and saltatory pattern if there are more than 25 oscillations. The minor criteria, if available, we can go for cord blood pH after delivery. So what to do? When we get a non-reassuring fetal status, we should not jump to going for an instrumental delivery or a cesarean section. First, we had to look for the cause. Is it due to maternal hypotension? And what are the means that we can promote fetal oxygenation? Maybe by reducing uterine activity and alleviating cord compression. So for promoting fetal oxygenation, lateral positioning either left or right of the mother, IV fluid, bolus of lactated ringer solution, and oxygen administration help. If there is tachysystole, that is more than 5 contractions in 10 minutes, we should stop oxytocin, give IV fluids, and again maternal repositioning may be done, and subcutaneous terbutaline, if available, can be given. Recurrent variable deceleration, if occurring in the first stage, we can go for amnio infusion, and in the second stage, if it's occurring, then we can go for modification of pushing efforts, that is, patient should not push with each contraction. She should give a like break while pushing. And again, if it is due to maternal hypotension, then repositioning and injection ephedrine. So the take-home messages are non-reassuring fetal status is an indicator that the fetus is at risk of hypoxia. We should not panic, but we have to become more vigilant. Intermittent auscultation and electronic fetal monitoring show no difference in outcome. And so judicious use of available facilities is recommended, and we should avoid using terms fetal distress and birth asphyxia interchangeably, and we should always use electronic fetal monitoring as an adjunct. And it should not be the only thing to make our decisions. We should use our clinical sense as well. Thank you for your patient hearing.
Thank you, Dr. Archana. Very wonderful presentation.
Thank you, madam.
And now we invite Dr. Ujwala. Dr. Ujwala, please come. Her presentation is CCTG benefit over conventional CTG. Mic over to Ujwala.
A very warm good morning to all the respected chairpersons and my dear seniors. I'm here to share my views on the benefits of computerized CTG over conventional CTG. So my Madam Archana Madam has talked a lot about CTG. So now I will be talking about the recent advances, that is the computerized CTG. So science is evolving, so should we. We know there are different methods of intermittent and continuous intrapartum as well as antepartum fetal monitoring. The most recent one is the conventional CTG. But what about computerized CTG? So we are living in the era of artificial intelligence. So the question is, why computerized CTG? Cardiotocography, as we all know, is the gold standard for fetal monitoring during labor. It is being used globally on a daily basis. However, its diagnostic accuracy remains unsatisfactory. Interpreting the CTG traces can prove challenging, mainly due to the significant differences in existing clinical practice guidelines. There is a wide range of inter as well as intra-observer variability between the maternity care providers. Historical studies on electronic fetal monitoring showed reduction in intrapartum stillbirths, but the subsequent randomized studies have not shown any reduction in perinatal mortality and morbidity. And one of the major reasons behind was the inability to interpret the CTG correctly. So the conventional CTG, as we all know, has a relatively low specificity, that is a high false positive rate, for identifying fetal hypoxia and associated complications. Incorrectly identified as normal, it delays necessary interventions, potentially increasing the risk of hypoxia or metabolic acidosis. Conversely, a trace incorrectly identified as abnormal may result in unnecessary interventions such as induction of labor or cesarean delivery. So the question is, can the current state of art be improved? The answer is yes. With the use of electronic algorithms implemented in the expert systems, we can minimize the intra as well as the intra-observer variability in CTG interpretation. Expert systems represent a type of applied artificial intelligence designed to assist in complex decision making. Computerized analysis of the electronic fetal monitoring overcomes these problems by providing a quantitative assessment of the fetal heart rate parameters. The first paper published in an index journal that has described a commercially available system for computerized analysis of cardiotocogram was issued in 1991. The paper addressed the typical why, what, and how questions that led to the development of Sonicate system by Dawes and Ridman. It has been assessed in several studies, including 2 RCTs and 2 meta-analyses. How many traces have we seen in our career, and how many can we remember? Even the most experienced observer cannot remember the huge range of patterns and what they signify. But the Dawes-Ridman analysis remembers over lakhs of traces. The Dawes-Ridman will provide us with 2 possible outcomes, criteria met and criteria not met. A computerized CTG can meet the Dawes-Ridman criteria in as little as 10 minutes. If the criteria are met and there are no other clinical concerns, the CTG can be considered as normal and discontinued. It does not need to remain on for 20 minutes. The Dawes-Ridman is an expert assistant. However, it also requires robust clinical judgment and confirmation. If the criteria are met, but the woman has clinical concerns that need obstetrician involvement, request a review. If the criteria are met and there are no additional concerns, obstetric review is not mandatory. If the criteria are not met, the CTG should continue for full 60 minutes. And if there are pathological features or any cause for concern during this time, immediate escalation should take place. The reasons why the trace did not meet the criteria are highlighted as coded numbers alongside the criteria not met message. This code should be evaluated with the appropriate risk factors. And if the trace appears normal at 60 minutes but the criteria is not met, the CTG should be discontinued and obstetric review should be short. So these are the various criteria not met codes. So the most important information that we get for computerized CTG is the short-term variations. Short-term variations are the micro fluctuations that cannot be seen by the naked eye. It is only the computer which analyzes the micro fluctuations in the heart rate. And if the short-term variations are more than 5, the fetus may have a problem but is unlikely to be hypoxemic. So we need to consider other clinical aspects of the cases, and it is more significant in preterm babies. If the short-term variation is 4 to 4.9, it is normal and does not need intervention. If the short-term variation is between 3 to 3.9, we need to repeat the CTG within 4 hours and notify the obstetrician. If the short-term variation is less than 3, it's a pre-terminal trace. Immediately notify the obstetrician and prepare for delivery. So as we can see in this picture, this is a conventional CTG, and we all can comment that the cardiotocography is showing the minimal baseline variability, that is less than 5 beats per minute. But the question is, how minimal? Less than 3, less than 4, or less than more than 5? So this is a recent analysis of the computerized CTG, and we can see in the picture, it shows all the number of fetal movements which can be seen in the per hour, and it calculates the basal heart rate. It is not equal to the baseline heart rate. Sometimes we have a problem in calculating the baseline heart rate in the conventional CTG. So the computerized CTG gives a basal heart rate. It calculates the contraction peaks. It calculates the accelerations, decelerations, high episodes in the minute, and number of low episodes. And it gives the short-term variations and analyzes whether the criteria are met and how much time, 60 minutes, 12 minutes. So we can see the first analysis says the criteria is met at 60 minutes, and then the first met at 12 minutes. And we can see there is written analysis is not valid during labor. So we cannot use computerized CTG during the labor. And this is not a diagnosis. We need our clinical judgment too. So coming to the benefits, computerized CTG is objective and reproducible interpretation. The accuracy is greater, results are presented quantitatively and consistently. It corrects the parameters analyzed for the gestational age. It reduces the time for interpretation. It assesses the short-term variation, which has been shown to be the best predictor of the fetal well-being. It reduces cost. We know billions are spent in obstetric litigations. If using the Dawes-Redman CTG analysis avoid just one poor outcome, it can save millions. Unlike humans, the Dawes-Redman analysis never gets tired. It does not need breaks, never gets sick or need holidays. It is always on hand at the bedside to help. So the question is, why computerized CTG in clinical practice? It's an initial will for improvement. We know the Foxy theme is Badlao, so let's bring this Badlao to our country. Coming to conclusion, computerized CTG is superior to observers in detecting decelerations, accelerations, and episodes of low variations and short-term variations. However, a CTG was not better in predicting low UPGAR score and need for NICU admission. Computerized CTG is not a replacement of the clinical judgment. Obstetricians should rely both on clinical features and on the computerized interpretation to make decisions on management. So these are the two famous scientists, Professor Chris Redman and Geoffrey Sherman Dawes, who invented this computerized CTG. And Professor Redman says, having identified the problems with traditional CTG interpretation, and after dedicating over 35 years ongoing research with the team at Oxford University, I'm delighted to see our analysis increasingly being used worldwide in Huntley's products, knowing the benefit this gives in helping babies to enter the world safely and avoiding some of the tragic outcomes we see when CTG interpretation goes wrong. Thank you.
Thank you, Dr. Ujjwala. Do we have studies comparing computerized CTG and conventional
Yes, ma'am.
CTG
There are
at your place at AIIMS Patna?
No, not yet, ma'am.
Okay, okay. Are you doing computerized CTG at
No,
AIIMS Patna?
we are still doing the conventional CTG.
Okay, so we should like progress towards computerized
Yes,
CTG. Okay, thank you very much. And
Hi, good morning, everyone. Now, the next speaker, I would like to invite Dr. Poonam Lal. She is going to speak on management of unforeseen complication of MROP.
Hello. Good morning, respected chairpersons, Madam Pramila Modi ma'am, and one and all present here. My topic of presentation is management of unforeseen complication of manual removal of placenta. After delivery of the baby, physiological separation of placenta occurs, then descent of placenta and expulsion of placenta occurs. And hemostasis is achieved by retraction of oblique uterine muscle fibers, vigorous uterine contraction following placental separation, and there is transient activation of coagulation and fibrinolytic system. If there is any abnormality in these, it can lead to retained placenta even after the active management of the labor, although the hemorrhage is reduced by 40%. Then why it is important to discuss retained placenta? Because 15 to 25% of maternal death in India are due to PPH. And if we see the primary cause of PPH, 10% causes are due to retained placenta or invasive placenta. When we see the incidence is 1 to 2%. It is less in developing country, but mortality is high. While in developed country, incidence is 3%, but mortality is very less. So, retained placenta after vaginal delivery is diagnosed when a placenta does not deliver within 18 to 60 minutes, or if a patient experiences significant hemorrhage prior to delivery of the placenta. Time factor varies according to NICE guideline. It is 30 minutes. WHO says it's 60 minutes, and a recent survey in Europe shows 30 to 60 minutes in absence of hemorrhage. But a recent study has shown less time, less morbidity. Then types of retained placenta can be, if there is failed contraction of myometrium behind the placenta, it can cause complete adherence. If it may be partial accreta. It can be trapped placenta. When the detached placenta trapped behind the closed cervix, it is very easy situation. We can relax the uterus and can, by slight controlled contraction, we can remove the placenta. But in first two, we need minimal removal of the placenta. Then what are the risk factors? We all know risk factor may be related to uterine atony, that is due to prolonged use of oxytocin, high parity. Risk factor may be related to abnormal presentation, like history of uterine surgery or IVF conception. Other risk factor may be preterm delivery, history of prior uterine placenta, congenital malformation. These, knowing these factors are very important so that we can try the patient. The recent multi-center retrospective study have shown that ART significantly increases the risk of retained placenta requiring MROP and PPH. Then management of retained placenta, medical management, we have tried oxytocin, tocolysis by sublingual glycerol trinitrate tablet, misoprostol, but they are not proven to be effective by randomized controlled trial. So answer is manual removal of placenta. This study have shown misoprostol is not effective if there is adherent placenta and does not seem to decrease the rate of MROP. The manual removal placenta is a painful procedure, should be done under anesthesia or adequate analgesia, fentanyl or ketamine, or we can use epidural, spinal. One should maintain sterility and follow proper steps of MRP, and uterotonic drugs should be given once the placenta is removed. If there is hemorrhage, we can do uterine packing or tamponade. We all know the complication of MRP can be life-threatening hemorrhage, endometritis, genital tract trauma, rupture, cervical tear, vaginal tear, inversion, and this is recent study, retrospective study have shown it can cause need of emergency intervention like blood transfusion, interventional radiology, and hysterectomy. So during manual removal of placenta, active management is important. It will prevent the 40% of hemorrhage. We should use prophylactic antibiotic, although nowadays it is controversial. One should not remove the hand during manual removal. In-out movement should not be done. It will prevent the infection, and entire birth canal should be inspected to make sure any lacerations should be repaired. Then what are the unforeseen complications of MRP? There may be hourglass contraction, there may be uterine inversion, there may be adherent placenta. Sometimes we do MRP and it is complete accreta. And diagnosis can be made by ultrasound or MRI antenatally or even during intranatal period. Hourglass contraction ring is very commonly encountered in our day-to-day practice. Placenta is trapped in the upper part of the hourglass contraction, and we are traditionally using halothane. It will relax the ring and we can remove the placenta. Now every anesthesia machine, newer machine, they are containing isoflurane and sevoflurane. These are causes slow relaxation of the ring, but there is less chances of hypotension and bleeding. So we are doing with this nowadays. Then this is a case of acute inversion after placental MRP presented to us with profound shock with ongoing bleeding. resuscitation was done with IV fluid blood and under broad spectrum antibiotic coverage, uterus was reposited back and uterine packing done, patient recovered well. This is another case when the inversion with placenta attached. In this case, one has to reposite back the uterus immediately with placenta. Placenta should not be removed. Then after reposition, then manual removal of placenta should be done, then uterotonic drug should be done, bimanual massage should be done, packing if required, and simultaneously resuscitation should be done. So maneuvers to be avoided like excessive traction on the umbilical cord, excessive fundal pressure, and excessively vigorous manual removal of placenta. Then management of placenta accreta. Whenever we do manual removal of placenta, sometimes we find there is complete or incomplete accreta. If there is complete or incomplete accreta with hemorrhage, and if patient is, there is profuse hemorrhage, if patient is completed her family, we can go for hysterectomy with blood transfusion. All forced counseling and consent is important. If the patient primary gravidence is bleeding, and if uterine artery embolism is available, we should go for this, it can preserve the fertility. Placenta partial accreta without hemorrhage, we can manage with methotrexate, hysteroscopic removal or uterine artery embolization. DNC we used to do, but nowadays hysteroscopic removal is more preferred. Then a newer study have shown that uterine artery embolization can be effective and safe treatment of RPOC with hemorrhage that can preserve fertility. And hysteroscopic removal nowadays by doing was done by morcellation or loop resection, and they are safe and there is no detrimental effect on the reproductive outcome and no significant effect on the pregnancy outcome. Before hysteroscopic removal was popular, I have managed 2 cases with the methotrexate when the placenta was 3 to 4 centimeter. 2 doses were given, and in one case when they not responded to methotrexate, I sent the patient for uterine artery embolization at Delhi, and the patient improved and she conceived later on. So to conclude, the retained placenta after vaginal delivery can cause significant hemorrhage and surgical morbidity to the mother. Recent research has suggested that shorter duration of 3rd stage may in fact be less morbid. Knowledge of risk factor allows us to triage those patients most at risk of hemorrhage. Prompt diagnosis and management, access to blood for massive transfusion, surgical equipment, facility for hysterectomy can save life of the mother. Uterine artery embolization is a safe alternative in placenta accreta when fertility has to be preserved. Hysteroscopic removal of retained placenta can be done with proper counseling and antibiotic coverage. Thank you.
Thank you, Poonamlal. That was a very elaborate and intense study done by you. And as we all know, that delivery of placenta is more fearful than the delivery of the fetus. So do you decide your medical management on the size of the accreta, 3-4 centimeter, or just amount of bleeding?
No, if amount
and parity.
If patient is bleeding and not responding, then we have to take decision. If it's multipara, we can do hysterectomy. But if it is adherent but not bleeding, we can leave and put her on antibiotic. We have to do proper counseling and take consent of the patient. Then small placenta is retained. Then I used methotrexate 2 doses 1 week apart, and it resolved. But larger placenta, they did not respond. I have done in many cases. So in one patient, 27 weeks pregnancy, it was primary gravida. There was 7 centimeter ultrasound size. Then I gave 3 doses of methotrexate because patient was not ready. That time we are not doing hysteroscopic removal. Then I sent the patient to Delhi for uterine artery embolization. Of course, the target firing should be done, otherwise there will be ovarian failure. And that patient responded well, and she conceives also. So uterine artery embolization is very important.
Yeah, the key factor
but if patient is bleeding, then only like in this case, there was no option. There was so adherent placenta, and patient wants pregnancy because 27 weeks baby was not alive. So we wanted to conceive, so I sent her.
Thank you very much.
Thank you. Thank you, madam. And now I will invite Dr. Archana Kumari ma'am for her presentation, Management of Macrosomia. Madam pranam and
Thank
please.
you, Aarti. I know she had been my student, and it is quite an honor that I am being chaired by you, respected chairpersons and learned audience. My regards to Pramila Modi ma'am, Kumkum ma'am, and Kiran Bhai ma'am for being here in the audience. Well, I feel privileged to be a part of this Labourcon being organized under the able leadership of Alka Pandey madam. Thank you, Dr. Supriya, all the organizing secretaries for giving me this opportunity. Well, the topic assigned to me is fetal macrosomia. So in next couple of minutes, I'll be discussing about the definition, the causative factors, a little bit about the pathophysiology, how to diagnose, what are the complications, including some of the long-term risk, and of course, then we'll discuss about the prevention and management. So definition, actually, macrosomia is defined as growth beyond a specific threshold, regardless of the gestational age. So in high-income countries, the most commonly used threshold is 4.5 kg, but weight above 4 kg is also commonly used. There has been a grading system where grade 1 is used for infant weighing from 4 to 4.5 kg. Above 4.5 kg to 5 kg is grade 2, and grade 3 is more than 5 kg. But using a statistical approach, we can define fetal macrosomia as any infant who weighs more than 90th percentile for the gestational age. So regarding prevalence, lots of different data are available. Worldwide, if we say it is 9%, but there are wide variation among countries. Prevalence among infant of low-income countries around 1 to 5% if we take the threshold of 4 kg. Now, what are the causative factors? Of course, we know about the maternal factors. Most common is gestational diabetes. But other than this, obesity, advanced age of the mother, post-dated pregnancy, multiparity, and constitutional factors are there. If we are able to exclude the maternal factor, we should think about some of the rare genetic syndrome which might be associated with accelerated fetal growth. Like one of them is Beckwith-Weizmann syndrome, which is associated with fetal islet cell hyperplasia with hyperinsulinemias. And of course, we might have to take the help of geneticists in these cases. Now, of course, the pathophysiology is quite clear. If it is gestational diabetes, we know it is a state of hyperglycemia in the fetus, which can lead to stimulation of the insulin-like growth factors, growth hormone, which of course stimulate the fetal growth and deposition of fat and glycogen, because we know that insulin is an anabolic hormone. Obesity itself can be linked with the increased neonatal mass, independent of the increased glucose intolerance which occurs in these patients. Advanced gestational age, of course, we know that growth will continue in utero due to the continuous supply of oxygen and nutrient to the fetus. Multiparity, with every new subsequent birth, the weight increases, and this reaches a nadir maybe of grand multipara at 5. We are rarely seeing these cases nowadays with the small family norm. And of course, the constitutional factors, taller and heavier parents tend to have a larger offspring. Now the diagnosis, ultrasound is the greatest friend of obstetrician, of course. So the diagnosis is dependent upon two-dimensional ultrasound examination. Hadlock formula has the highest predictive value in the non-diabetic population, but there are measurements of fetal volumetric analysis which can give a better analysis. An abdominal circumference of more than 35 centimeters is also predictive of macrosomia, but no test is highly sensitive and specific. And of course, in the era of artificial intelligence, a neural network computerized model can help in diagnosing us, but of course, this is still investigational, but it can be promising in future. Are there any novel biomarker for macrosomia? Well, there are studies which shows microRNAs are involved in placental growth and development, and thus they may affect fetal growth and size. There are maternal glycemic marker like insulin-like growth factor, etc. But currently, the measurement of these markers has no clinical role. It warrants further studies. Regarding screening, of course, no guideline recommends universal screening for macrosomia in the general obstetric population, but selective screening in 3rd trimester has to be done in following clinical scenario, which we discussed already: maternal diabetes, particularly if the glucose level are poorly controlled, previous macrosomic newborn, and of course the previous history of soldier dystocia. Why it is important to know about fetal macrosomia? Well, because there are risk of adverse outcome which increases along the continuum based on the degree of macrosomia from 4 to 4.9 kg. So more than 5 kg, of course, the risk of stillbirth and neonatal death also increases. And for this reason, the presence of macrosomia is an important factor to be considered in the decision making for delivery. We all are aware of the complications which can occur. There are intrapartum complications like protracted or arrested labor, assisted vaginal birth, increased cesarean delivery rate, extension of uterine angles, postpartum hemorrhage, and uterine rupture. Recently, just 2 weeks back, we came across one interesting case which was referred to us to our medical college from Sadr Hospital. She was gravida 3, previous 2 vaginal deliveries, cesarean was done for big baby about 4 kg size. And there might have been extension of the uterine angle. The uterus was closed and abdomen closed. 6 hours later, when the patient was found in a state of shock, she was referred to us. Re-laparotomy was done, and this was the picture. There was big bladder hematoma and hematoma extending up to the vault, and in this case, we had to do the hysterectomy. The fetal complication, of course, shoulder dystocia is the most serious intrapartum concern, which we obstetricians are always feared about. Then, of course, fetus more than 5 kg may have increased risk of stillbirth. In neonates, there's increased risk of hypoglycemia, respiratory problem, increased frequency of admission to NICU, and of course, there are long-term complications like obesity, impaired glucose tolerance, metabolic syndrome, and cardiac remodeling. So the consequences of macrosomia will vary according to the etiology. Now, prevention, of course, in case of GDM, we have to do the strict glucose monitoring. In patients with pre-gestational diabetes, maintaining the blood glucose level around 100 milligram per DL is, will help in achieving the macrosomia rate comparable to the general obstetric population. And of course, in patient with obesity, the weight loss is important. Pre-pregnancy bariatric surgery is important in those with morbid obesity because substantial weight loss is probably not safe during pregnancy. Now, coming to the management of the shoulder dystocia, which most obstetricians fear of course, we have to call for help. We have to do Macrobert's maneuver, that is putting the patient in extreme lithotomy position because that will cause the cephalad rotation of the pelvis, and along with this, give a sustained suprapubic pressure in the downward and direction opposite to the anterior shoulder. And along with this, we have to give a sustained downward pressure. And if this is not successful, we might have to do the release of the posterior arm. We have to go along the fetus aspect of the chest, hold the wrist and bring it downwards along the chest. If this fails, we have to go for rotational maneuver like Lubin 2 maneuver. We have to place 2 fingers on the back and rotate 30 degrees towards the fetal face. And if this is not happening, then we can use another hand on the front of the posterior shoulder and rotate the fetus by 180 degree. And of course, we know all that oblique diameter has greater dimension than the anteroposterior diameter, so these maneuvers do help. And sometimes we have to do the rescue like Javanelli and abdominal rescue procedure. So to conclude, I'll say fetal macrosomia is an important risk factor for operative delivery. Important factor in decision making about the delivery, 2-dimensional ultrasound is the standard modality. And of course, we have to take the preventive measures in gestational diabetes and obesity cases. Thank you so much for giving me this opportunity. I bring gratitude from Jharkhand. I must congratulate Alka Panna Madam for this excellent Labourcon, which is being held under her able leadership. Thank you so much.
Thank you so much, Dr. Archana, and for your excellent and informative deliberation. Thank you so much. Now we would like to invite Dr. B. Kalpana. Dr. B. Kalpana. She will speak on thyroid storm in pregnancy. So welcome Dr. Kalpana, Dr. B. Kalpana Madam.
Good morning, everyone. First of all, I would like to thank organizing chairperson Alka Pandi ma'am and Dr. Supriya and the whole dynamic team of Patna who had taken efforts to organize such a wonderful program. Even though we have a great audience, even at 8:30, I also thank that we have Kiran Mai, Asha Bakshi ma'am and Kavita ma'am who are here even at this hours. So, thyroid storm in pregnancy, we need to know in detail about thyroid storm in pregnancy because not only because it is associated with great maternal mortality, but also it is easily preventable one. So thyroid storm is a rare complication and almost it is associated with 10 to 30% maternal mortality. Hyperthyroidism, when we look into it, it is quite rare compared to hypothyroidism, which is quite common. Actually, 1 in 1,000 would develop hyperthyroidism, and mostly it is due to Graves' disease. Sometimes it may be due to multinodular goiter, single nodular goiter, or sometimes subacute thyroiditis. And so many times we need to think about Graves' disease. But in hyperthyroidism, almost thyroid storm is quite common, 10 times more common than normal patient. Many a times it has been precipitated by various factors like even delivery, cesarean section, infection, preeclampsia would precipitate thyroid storm. So incidence is quite rare. 1 to 2% of thyroid storm, hyperthyroidism patients go for thyroid storm, and we all know the complications related to hyperthyroidism in pregnancy. Maternal complication could be preterm labor, miscarriage, sometimes preeclampsia, but neonatal fetal complications could be stillbirth and effect of thyroid disorders on fetal thyroid. So thyroid storm can be impending thyroid storm, early stage or acute crisis, and impending storm should be diagnosed with Bush point scale. This has a scale of temperature, cardiovascular system tachycardia, congestive cardiac failure, evidence of gastrointestinal hepatic dysfunction, central nervous system dysfunction. Sometimes precipitating factor should also be looked into it. So if the score is less than 25, the storm is quite unlikely. But if it is 45, more than 45, you need to expect and always have a cautionly, you just monitor temperature if it is more than 39 and pulse rate more than 120 with the symptoms like irritability, nausea, vomiting, you suspect there is a possibility. And thyroid storm is diagnosed if temperature is more than 39 and pulse rate is more than 160 and there is disturbance in consciousness level also. So we all know that precipitating factors. So many a times in unbooked case, sometimes even if we take the patient for cesarean section, the storm you can encounter immediately after cesarean section also. So always have a look on it, because if pulse rate and BP, if it is inconsistent with the depth of anesthesia, thyroid storm should be considered in these patients. The differential diagnosis you should also think is malignant hyperthermia and inadequate analgesia, but in malignant hyperthermia you will always have muscle rigidity and management. We all know that hyperthyroidism should be corrected with propyl thiouracil. Heart rate should be brought down to a normal level with beta blockers, and steroid should be given in Graves' disease. Oxygen, if saturation is falling down naturally, volume management should be very careful, and antipyretics to reduce the temperature, and electrolyte imbalance should be corrected. And always suspect the possibility of thyroid storm if there is a great weight gain and pulse rate more than 120 beats in 20 for 2 months almost, and Thyroid storm management depends on PTU, always with Ryle's tube. If the patient is unconscious, with Ryle's tubes, Lugol's iodine and dexamethasone should be considered. We all know the mechanism of all these drugs, and if the patient is in heart failure, combined treatment with cardiologist, with diuretics and morphine can also relieve her pain. These are few cases. This is undiagnosed hyperthyroidism, a cesarean section done. Immediately after extubation, the patient had tachycardia, agitation, and heart rate was 130, and patient was responding to all our comments. And there was a great increase in weight, and the problem with the cesarean section is we should avoid the drugs which would increase sympathetic hormone release and histamine release. So at that time, heart rate went up, BP went up, and thyroid palpation released thyroid hormone, and it was worsening at that time. Thyroid function test was done with a suspicion, and steroids started, and beta blockers also given, and heart rate came down. TSH was revealed hyperthyroidism, and we treated the patient with, neonatal hyperthyroidism should also be screened. Those neonates should be treated with that. So always when you suspect thyroid, hyperthyroidism and thyroid storm, go for general anesthesia rather than spinal, and trachurium ketamine should be avoided in these patients. This is a review involving 4.2 million births. They concluded that there is an increased risk of atrial fibrillation, congestive cardiac failure, mechanical ventilation, and depression. Also, as far as the fetus is concerned, preterm birth and stillbirth is significantly increased. Many a times in hyperthyroidism, patient come to us with symptoms. In that occasion, shortness of breath, palpitation, and suspect if pulse rate is more and BP is more and oxygen saturation is falling down, always suspect thyroid storm. This is the diagnostic algorithm. When a patient is presenting with fever, tachycardia, cardiac failure, GIT symptoms, and disturbance in consciousness, in addition to all other differential diagnosis, always think about thyroid storm. Resuscitate the patient initially with the airway, breathing, circulation, but always take a history, previous history of Graves' disease or any thyroid disease. Check her hormones, and if it is abnormal, if Dopplers can also help. If it is increased, could be a Graves' disease. If it is reduced, yeah, I'm just moving. One more slide only. Destructive thyroiditis should also be considered. So treat appropriately if storm is confirmed. So to conclude, pregnant women should be screened for universal screening of thyroid disease is recommended, and pulse rate if it is persistently more than 100, and there is a great weight gain in these patients, rule out hyperthyroidism. And when you are doing cesarean section, there is a possibility of thyroid storm. So be careful, avoid sympathomimetic drugs and histamine releasing drugs. And if there is a patient who is having uncontrolled hyperthyroidism, avoid conception using some contraception methods, preferably barrier method, IUCD, or sometimes tubectomy to avoid thyroid storm, which is having great maternal mortality. Thank you.
Thank you, madam, for your nice and elaborate presentation. We need a well-controlled thyroid profile or thyroid hormone levels before a woman enters into pregnancy. And with this, we now conclude this session, and the house is open to discussion. If anyone would like to have a discussion with our speakers, they may. The last 10 minutes is for discussion. So, okay, the house is open for only 1 or 2 questions. I hope no question. Thank you. Okay, okay.
Yeah, actually universal screening, as per ASHRAE guidelines, universal screening is definitely recommended. And it has been recommended that TSH should be brought to 2.5 in first trimester, and second trimester it should be 3. And even though there is a controversy between American Thyroid Association and European Thyroid Association, third trimester, many a times it is considered as 3. So at least in each trimester, preferably from 8 to 9 weeks, before pregnancy, 8 to 9 weeks, and then at least each trimester it should be checked.
All right, I believe.
Thank you very much. Now we conclude this session.
Thank you so much. With that, we would like to get started with the next session on time as well. Thank you so much for the chairpersons. Yes, we can have a picture. Can I have all the speakers for the first session and the chairpersons? You can be on the stage and take the picture also, ma'am. No problem. Yes, yes, for sure. Itna to haq banta hi hai, even though we started a few minutes late. But we've concluded on time, and it's not a job that can be done alone. It's a team effort together. And I would like to thank the chairpersons. Yes, please. All the speakers. Yes, please look into the camera. 3, 2, 1. Wow, दे देंगे वो sir, दे देंगे आपको. He's from Mayor Antibiotics, no? Mayor का ही दिख रहा है ना? नहीं. Thank you. उज्ज्वला के पास है. उज्ज्वला सबको please आप दे देना. Group पे भी forward कर देना. Now I request the chairpersons for the next session to please join us. We have Dr. Kumkum Sinha, Dr. Bindu Sinha and Dr. Mukta Agarwal. To save time, can I also request our first speaker, Dr. Sadhana Gupta ma'am, to please join us on the dais. Total time is 13 minutes per speaker. Can I request Dr. Abharani Sinha to also chair the session if 45 minutes? Yes, ma'am. And I must say, I really like the color of your sari, ma'am.
Nikhil shouldn't comment on that.
मैं बाकी का तो कुछ कमेंट कर ही नहीं सकता हूँ, डॉक्टर तो हूँ नहीं तो. ये लो.
On hai. Good morning, everybody. So we start with the next session, and this is doing with catastrophic complications in labor. And the first session is on innovations in managing PPH. And the orator is none other than Dr. Sadhana Gupta to give a short introduction of her. She is co-chair, SO Suffolk Committee and Foxy representative to Suffolk. Vice President Foxy in 2016, ICOG Governing Council member 2015 to 21, corresponding national editor, peer review, Obs and Gynae India, and she is Foxy past chairperson, Safe Motherhood Committee, thrice country representative to World Health WHO, and 3 times Korean Award winner for Best Scientific Research Paper, 4 times Best AICOG research paper, sole author of book on cesarean delivery, vaginal delivery, editor 7 Safe Motherhood Bulletin, awardee 3 times of Foxy Dr. D.C. Datta Prize, awardee of Chancellors and Dr. Naval Kishore Gold Medal for Best MBBS. And of course, she's got so many awards, and she is also director and senior consultant of Obs and Gynae, Jeevan Jyoti Hospital and Medical Research Center. So we would request Dr. Sadhna Gupta to start her talk on innovations in managing PPH. Over to you, madam.
Thank you. A very good morning to everyone, and my regards to chairpersons for a generous introduction, and thanks and congratulations to Dr. Alka Pandey, Dr. Vinita Singh, Pragya, Meena Samant for this wonderful conference and all the opportunity to be together. So I will be dealing what happened new in the postpartum hemorrhage in last few years, we can say 10 years, and a gratitude for Patna and Bihar to be always together in my journey, and whatever I am today, the teachers, mentors have contributed a lot for this, for whatever I have done in the professional organization. I seek everybody's blessings and support for my Foxy presidential candidature, and we have to be peaceful in the outer world until we make peace with ourselves. This is land of Buddha and land of saints, and as a doctor, we have to be very, very peaceful with ourselves. So PPH global perspective, we all are aware that it is contributing still to 30-35% of all maternal death, and Africa and Asia constitute major portion of these deaths. So India is the same. We have crossed many statistics, improved maternal health statistics, but the PPH remains the very, very important cause of near miss as well as the postpartum hemorrhage. But actually global statistics does not trouble us our clinical patient, our clinical experience. And when we lose certain patient with postpartum hemorrhage, it is a demoralizing for like a lifetime scar, not only to the patient, but also to the doctor. And all obstetrical hysterectomy, ICU, massive blood transfusion, they are all considered into the near miss and the same. So it tests, PPH always tests your guts, your leadership, your system, how it is effective, because we can lose the patient in short span of 1 to 2 hours. So what has been new? So one is the postpartum hemorrhage care bundle, and as a Foxy presidential candidate, it is my worst vision that approaching of the care bundle approach and bridging the gaps into the maternal health care. And these are the first respondents refractory to response, what is the uterotonic crystalloid tranexamic massage, and the second level action. So what is the E-motive bundle? A lot of research, we still don't know that what actually implementation will take, what resource and the other thing, but we have to be knowing out that it is an E-motive, that is the early detection, uterine massage, oxytocin drug, tranexamic acid, IV fluid, examination of genital tract, and escalation when necessary. So this trial is registered, and within 1 or 2 years we will have certain data. So what has been the innovation? Because when we lose patient, when we see the criticality, that is so inspiring, that motivates us to our brain think, then heart aches, and we have the innovation. So just I was in Jorhat last 3 months ago, and I saw the water ambulance, a pregnant woman carrying from Mugli to the Jorhat. And that water ambulance, it is an innovation because we want to cross the barriers. And likewise, like 10 or 15 years ago, we started 108 and a good road. And these are also innovation. It is innovations are not only in the science. About medical management, what is there? The important concern is that the pipeline for new PPH medicine is currently limited, and that should worry us. We are having around 100 drugs in the cardiovascular, so many drugs for the rare situation, but PPH, which is affecting a lot of women, we are not having that good amount of drug. Few we have the experience in last 8 to 10 years, that is meso, tranexamic acid. Now we have long-acting oxytocin around 1.5 years, and recombinant factor 10, factor 7. So we have to have, the future is for the inhaled room stable oxytocin, synthetic plasma expander, drug which act on the coagulation system, and effective, affordable, accessible drug for the PPH. So this is a short review. Misoprostol is a drug which has come to us rescue, but I just want to say that it also have the degradation, like it has to be kept away from heat and the humidity, and it is a second line drug for the PPH management as well as in the prevention. So this is important because nowadays we are using it. Tranexamic acid after women trial has come into big way, and it is a recommendation that in all high-risk cases, prophylactic PPH, prophylactic tranexamic acid, and in the setting of PPH, tranexamic acid should be used early in the first hour and repeat within 3 hours, and there is no advantage after using it after 3 hours. So after women trial, we have a strong recommendation, and I appeal everyone that they use tranexamic acid in high-risk cases and the early institution of the tranexamic acid. One point I wish to highlight, that is in our National Medical Council as well as the papers from the anesthetic, that we have the same injection tranexamic acid and the bupivacaine, and there have been accidental injection of tranexamic acid has been used as local anesthesia, which have led to mortality. So innovations are not, you keep magnifying glass in your OT so that there is no confusion, because we are having the real lifetime situation. Recombinant factor 7A, now we have used it. Important thing is that we still don't know that when it is effective. However, when you use it, it should be used early into the management of PPH and not too late when there is a irreversible shock or something. So it is important. Issue is dose is 60 to 80 microgram per kg. Important thing is we don't know still what is the exact dose, timing and frequency, and high cost availability of drug. When you have drug, there is no need, and the drug get expired and then you don't have. So there are few things, but it is expensive, short life, and it is marginally effective. AMTSL, we have come a long way, that we have to add oxytocic agent within 1 minute of birth of baby, late clamping of cord, CCT only when the skilled birth attendant is there, and uterine massage not recommended. So I was the part of the project when Dr. Hema Divakar was president, and the path study before that, nobody was aware that the oxytocin has to be kept in refrigerator like vaccine. And when we needed oxytocin most, it was not effective. That came to the search of the room stable, heat stable carbitocin. Now we have used, and it is a joint effort of FARING, M4M and WHO. They wanted some effective drug at the bedside of the patient. Champion trial was India was the important contributor of the Champion trial. We did the research very well, we contributed very well, and now it is available. So what is the beauty of carbitocin? That it is a long acting, it is a room heat stable, it has a plasma life of 40 minutes, and especially in high risk situation when we don't want to have the fluid overload like PIH, severe anemia, it is a very, very good armamentarium for the active management of third stage of labor. Every drug has few caution, never to be used for induction, and it is more studied in cesarean, but I think in next 2 or 3 years, a lot of teachers and research settings are there, and even private practitioner can contribute, that it is a very good effective AMTSL active management of third stage of labor, even in vaginal delivery, and 400, 300 rupees is not a cost issue. So carbitocin is has got a lot of advantage versus oxytocin, and this is the thing that in clinical setting, we must give the advantage of these new drugs to our patient. So these are the studies. So again, I say that it is important that the national and international guidelines say that we, as a FOXY, as a professional organization, that carbitocin can be used as a standard drug for the AMTSL. We still have a lot of trial that cesarean versus vaginal delivery. So it is important, and what next, be ready for the future. So again, I say there are very limited number of drugs which are being used for the postpartum hemorrhage. Few are good efficacy, good potential, few are medium. So heat stable inhaled oxytocin is one of the drug which has the high potential in the currently in the phase 1, and it has a high potential in our region. Melatonin has come in a big way. This is the drug of medium potential candidate, because the melatonin level peak in pregnant woman just before birth. So melatonin is again a medium potential drug. Vasopressin is also medium potentially drug, and it has been phased in the phase 1 and phase 2. Dofletide, this is an antiarrhythmic agent. It is a promising, however, we are not sure about the non-particle delivery, but I want to know that these are the drugs where the research are being on, and we must have 1 or 2 drugs in the next 10 years beside our conventional armamentarium. Many, many herbal supplements are there, but we don't have that. A consistent data and the biological plausibility of supplement is uncertain, that how we will extract from the fod. Fibrinogen concentrate, ethamsalide, and the propanol are the uncertain potential, yet the research is going on about it. So issue and concern is that there is a gender discrimination in the world of science and and the drugs which is affecting women health by and large, the research is not investing in that emphatic manner which is actually needed. So innovation, now these are, it is really matter of pride that many innovation has done right from our country and our area. So estimation of blood loss, we know the most important pitfall that we lose the golden hour because the nurses or the junior resident or sometimes consultant even fail to recognize how much blood have lost. So it is Devdas bag, our own Alok Devdas, a wonderful technical mind. We had we could not have the commercial production, and it is also said it is color coded alert and action line. So it is very important. Now Nalini Mishra has done, we have the safe delivery kits in our all setting. So right from that plastic apron which we turn around our neck during delivery, this bed drape can be prepared right at the spot. So it is prepared spot, easy to make, easy to use and easy to dispose and detect PPH in real time and around only 15 rupees. So it is a plastic apron which is stapled and which is make cone, and it makes you the accurate estimation, and right at the moment of the labor room you can make it. So this is the Chhattisgarh drape which has taken, and again Nalini has done the Chhattisgarh balloon. Now it has been propagated by us in many workshops, and the beauty is that it has got the drainage channel. It can be easily made. It is not only even costing 500 or 600 rupees, what to say 12,000 of bakery balloon, and if we train the people can use it very easily. And in our all programs we have been propagating this thing. So these are the important drainage lumen, no suture material, no need to occlude the distal end, insertion easier and definite landmark, and it remains within the uterine cavity. So it is just our mind which makes us think that what we can do to our patient. Now the SR cannula and Penneker cannula, these are the great person who are working in a remote and the peripheral areas, and it is a simple law of physics which never fails. And whenever we are doing this PPH workshop, people are having such a good lifestyle. Muzaffarpur, Siwan, we have PPH workshop, and the people were sharing that how effective it is. So it is a suction cannula. You need only that suction cannula, high vacuum suction pump, and the thick walled flexible plastic suction tube. So you have they have made different size. So for uterus there are different holes. For the cervix it is a smaller hole, and because it is on the principle of physics, it never fails actually. So what the Samartha and Penneker says that if you use Penneker cannula, you are no need to use for the internal iliac or the compression suture, and they have the wonderful papers also about it. It is a research proven, and in all international studies it is being taken as a very effective measure, not only for atonic but sometimes for the traumatic PPH. So this SR cannula, we are so much fond of costly, invasive. It's actually like a diamond or jewelry, it attracts us. But what we need actually the simple, comfortable things which we can do. It is, I think, 2 minutes. It is a 9 minute is showing. It is 2 minutes, not 30 minutes. So the cannula should be made part and parcel of labor room equipment and the train. It's not moving. It is not moving? Yes. Bilateral uterine compression. So it is Nina Gideon, and I will say that be proud of them, and we have to propagate there. So Nina Gideon, it is a uterine artery compression, bilateral uterine artery compression, and a very good effective measure. It can be done by any level of the healthcare, any level of the basic obstetric and gynae, and she has also published few papers, and in difficult situation you can really help on it. Our VP Pelli. So especially for the young generation, don't confuse GAT with the hi-fi things and the something. We have to know our own peers, Dr. P.P. Pelli, who has done the 10-year confidential inquiry into maternal death into the Kerala, and what a wonderful innovation that is aortic clamp for the placenta accretus spectrum or any life-threatening hemorrhage and transvaginal uterine artery clamp. So his paper has been published, his paper has been recognized at national and international level, and when you use the aortic clump, there is no need for vascular surgeon, there is no need for internal iliac ligation, because there are a lot of collaterals, and aortic clamp take care of that. And this is transvaginal uterine artery clamp. You can apply clamp uterine artery right from the vagina. You can take time to shift to OT, you can take time to transfer to tertiary level care, and it is never. I will take 1 minute. And then non-pneumatic anti-shock garment, again it has been tried into the ward setting. Bimanual compression, all teachers which are sitting before us, we know that we are losing art of bimanual, like the obstacle maneuver, and so today it is PPH butterfly, which makes you give a good amount of bimanual compression in a good way. Thromboelastography is a costly thing, but in coagulopathy it can be really added to it. Rotational thromboelastography is there, so, but important thing, we actually don't know how it is being read in clinical setting and how it is cost effective. So point of care test remains with us, and this is again a good paper by Dr. Nalini Mishra, that we can lay the point of care test which correlate with the fibrinogen level very well. Dissemination of skill and knowledge. So since 3 years with the COVID, we are regularly having e-classics for clinician, and we are reaching to all societies.
Apologies,
we are in the workshops, the physical as well as the thing. So it is not that the knowledge to be kept for us only, it is important that this knowledge and skill to be transferred at every city, because we want to save mother everywhere. It is our passion and profession. So simple thing matters most for many. High tech is needed only for few select situations. So I seek your blessings, guidance, support to my Foxy presidential candidature. I am ready with my Foxy vision, what is needed in our country in the last 30 years of the journey.
We can
Foxy.
have the next speaker,
please. I request everybody's support for my Foxy presidential candidature. Thank you very much.
Thank you, Dr. Sadhana Gupta. Such a wonderful talk you gave. You traced all the history from bimanual compression, oxytocin, then going to misoprostol, then all the way down to carboprostol. And then you have also told us about the latest innovations that are on the way and the research papers that are going on. Very nice.
Thank you.
So,
thank
you so much.
Thank you, Sadhana ma'am. And now I would like to invite our next speaker, Dr. Asha Bakshi madam. And madam is lead consultant at Dr. Asha Bakshi Fertility Center. Madam is holding many high posts in the Foxy and in the society. And madam has organized many national, international conferences and being the organizing chairperson for ISAR 2016 and AICOG 2022 Indore. Welcome, madam. And madam will be speaking on pre-ART and care during ART to improve the obstetric outcome. So please welcome Asha Bakshi ma'am.
Thank you very much for the kind introduction. And first of all, I would like to congratulate Dr. Alka Pandey and her team for such a good conference, such a good show. And now I'll be talking about pre-ART counseling and care during ART procedure to improve our obstetric outcome. We all know that millions of children have been born through ART procedures. In certain countries like Australia, every 20th baby is born through IVF. In India also, there has been an exponential rise in IVF procedures and the pregnancies resulting out of it. And these are the data in my own hospital, where last year, out of 786 pregnancies, number of IVF pregnancies was 101. So that is every one pregnancy was there with IVF when there were 7.7 pregnancies to normal conception. So this data is really alarming, but this is a misnomer because I work there, so I have an IVF setup. So naturally the pregnancies, but there are many other consultants in the hospital who are not doing IVF. So what I mean to say that there is a reflection that yes, IVF pregnancies are on a rise and we all are going to see more and more pregnancies conceived through IVF. And out of these 101 patients who conceived with IVF, now only 14 patients delivered vaginally and rest all had cesarean. Now cesarean could be because of many obstetric complications. At the same time, to be honest, there is always a low threshold for doing cesarean for IVF. And many a times you encourage, because I am the one who always encourages these patients to deliver normally. But then many a times it is the patient, her in-laws, who force you to do cesarean. But then this is how the obstetric complications go away. Whenever we do IVF, the embryologist is very happy that yes, I've got eggs and good sperms and good embryos. The clinician is very happy that yes, now there is a good heartbeat. But that is not it. What we need is a healthy baby and healthy mother with lifelong wellness, and that is most important. And why these ART pregnancies are at risk of obstetric complications? That could be because of the advanced age, associated medical problems, multiple pregnancies, and there are certain problems which are intrinsic to IVF, and that is because of controlled ovarian hyperstimulation, culture medium, temperature, and so many other odds. And we have all heard about these epigenetic changes. And what we know is that these epigenetic changes, they affect the babies. But now recently what they have found, that even in the placenta, there are epigenetic changes. And because of these changes, we see that there is abnormal trophoblastic activity, and we find more of placenta accreta, percreta, and poor placentation. So maybe this also has some role. So very important, though these things may not be avoided, but if we keep the exposure of embryos to minimum and avoid excessive handling, maybe up to some extent there may be a help. Then what are the obstetric complications? We all know multiple gestation. Placenta is the biggest thing, and that is placenta accreta spectrum, previa, abruption. Then hypertensive diseases of the pregnancy, premature rupture of membranes, preterm labor, and IUGR. So pre-ART care, we all talk about the preconception counseling, and ART offers the best opportunity for preconception counseling, as these are the planned pregnancies and patients are receptive to the advice by the gynecologist. And whenever you see a patient, it's very, very important that a very detailed history, not only of just her obstetrics and gynec, but even medical history has to be taken, or her husband's, and that has to be taken separately, and ideally this should be signed by the patient. So this is the form I've downloaded from ASRM. Vaccination is very important in these patients during the preconception care, and you can easily prevent influenza, varicella, and all those things. So a good counseling here is important. Then obesity, very important to maintain a good weight. And we all know that a good weight management is significant, is very important, because excessive weight is directly associated with maternal morbidity, increased risk of gestational hypertension, preeclampsia, diabetes, dystocia, labor induction, all those things. So very, very important that we advise the patient to optimize her weight. Then there are lots of medical disorders that can be screened beforehand. And most important is these patients are usually elderly and have got lots of medical problems. So please screen for all the medical problems, and especially heart. We do everything, but we ignore heart. So in my clinic, I've made a rule that if there is any lady about 35 years coming for IVF, we usually do her echocardiography, and even during the pregnancy, we do the echocardiography. Then structural anomalies, they can be corrected. This is a very good opportunity. And we all know that if there are uterine malformations, then they are associated with increased risk of not only miscarriages, but lower birth weights as well. Then, and live birth rates as well. And these are the various studies which suggest that yes, the Mullerian anomalies do have effect on the obstetric outcome. Now, and we know that hysteroscopic septum resection can not only help in achieving good results in IVF, but in the long term, it will help in having good results, obstetric outcome as well. Then ovarian hyperstimulation, this you can see is a very old slide. So that says that mostly now everybody is so conscious about ovarian hyperstimulation that we are trying to go for ovarian hyperstimulation free clinic. But still sometimes it does occur, and if you have transferred the embryos, then that is associated with a poor outcome. So better to go for freeze-all policy. And this may lead to early and late miscarriages, ectopic pregnancy, prematurity, low birth weight, pregnancy-induced hypertension, diabetes, and all sorts of problems are more common when you transfer transfer embryos in a patient who has got ovarian hyperstimulation. Then effect of endometrial thickness. You all must be knowing that most of the times people are very fond of doing transvaginal sonography. And a very good idea is that you do a transvaginal sonography of these patients who want to undergo IVF or between day 10 to day 16. So that is the time of ovulation, and that is the time you'll be able to assess her endometrium, how the endometrium is, whether it is good 3-line endometrium or not, how, put in some Doppler and see what are the blood flows like, and that will really help you assess, because at the time of embryo transfer we want a good endometrium. So we all know, and there are studies that thin endometrium is again associated with lots of complications like hypertension, preeclampsia, HELLP syndrome, all these, and IUGR and oligohydramnios and premature rupture of membranes. So this is a paper where they have shown that endometrial thickness less than 7 millimeter was associated with high risk of premature labor, and endometrial thickness, though besides that other things were not that common. Then this is another paper where they found that thin endometrium is associated with hypertensive disorders of the pregnancy. So again, very important to pay a lot of stress on endometrium. This is again another paper where they have done frozen embryo transfer, and they found that endometrium less than. So usually people want endometrium above 8 millimeter. It should be a good 3-line endometrium with good blood flow, and usually that gives us very good outcome. And if it is not so, if the endometrium is not that good, then please wait, give her HRT, and you can give, these days lots of regenerative things have come up like PRP, so you can inject PRP in the endometrium, and these things may help in improving. And many a times you do a good hysteroscopy, there may be flimsy adhesions, and these patients, if you give HRT for 2-3 months, then it really improves. But PRP has come long way, and I have had a patient who had refractory thin endometrium, and then with good HRT, and there are now commercially PRPs available. People come and do it at your own place, and they put in some growth factors also, and we got very good endometrium, and the result was very good. So there are various ways of preparing HRT also. Then isthmosil, this is a new iatrogenic complications, and there have been studies which have shown that if you do embryo transfer in patients who have had previous cesarean, the implantation is not that great. And isthmosil, again, if the implantation occurs in this isthmosil window, then there is a good chance of scar ectopic pregnancy and scar dehiscence. So this has become a new iatrogenic problem, and most of us are facing this, and this is mainly because of increased incidence of cesarean. So what to do in these patients? How can we prevent scar ectopic pregnancy in these patients? So it has been suggested that instead of doing a day 3 transfer, you do a day 5 transfer when uterus is less contractile, and that time if you do the transfer, then the chances of scar ectopic is less. And again, in these patients, avoid pulling the cervix, so that the embryo transfer does not go, catheter does not go in that window. And the third thing is maybe atosiben may have some role. So again, fibroids also, we know that fibroids do have a poor obstetric outcome, and wherever required, if you can remove, then it can give you a good outcome. Then endometriosis, again a controversial issue, whether you should treat the endometriosis or go straight away for IVF. What I would suggest that if it is a severe endometriosis, then please retrieve the eggs first, form the good embryos, then give good GnRH analog or whatever operative you want to do, treat the patient, and once that endometriosis is less angry, because I feel endometriosis gives lots of inflammation, and someone has described this as toxic pelvic cavity syndrome. So if in that you are going to transfer the embryos, the outcomes are not that good. So better to control the endometriosis and do the embryo transfers later on. Maybe you can do a frozen embryo transfer. So these are all the complications which have been found with the and patients who have conceived with active endometriosis. Then endometrial preparation for frozen embryo transfer. You all know that when we have chances of ovarian hyperstimulation, or when there are excessive embryos, then we vitrify these embryos and transfer them at later stage. So traditionally people had been transferring into HRT cycle, means you give estrogen and estrogens, prepare the endometrium, transfer the embryo, and then you give progestogens. But it has been found that when you do HRT cycle transfer, the results are not that good. But if you do transfer in a natural cycle or a letrozole cycle, the results are good. So these are various studies which have shown that the results are good if you do it in a natural cycle. So, but only thing is you have to be very watchful, and sometimes when patients have had premature ovarian failure, then you can't do transfer in a natural cycle. In those cases, you have to do HRT cycle. Then perinatal outcomes again are have been described according to the various protocols, and it has been suggested that preparing the endometrium using ovarian stimulation or HRT protocol has increased the incidence of preeclampsia, intrahepatic cholestasis of pregnancy. Then another thing is about the donor oocytes. A patient has not conceived in first cycle, second cycle, people easily offer the donor cycles. So that has again to be taken with a pinch of salt, because donor cycles are again associated with increased risk of preeclampsia. It's not moving. Nikhil, it's not moving.
Yeah, maybe the time is up.
Can I just
people,
conclude my slide, please?
Yeah.
So the most important thing is avoiding multiple pregnancies. So we have to transfer single embryo transfer. That is the recommendation, and we all have to see to it that single embryo transfer is being transferred, because multiple pregnancies are associated with perinatal as well as obstetric outcomes. And even people say that, okay, I will transfer two, most probably it will be one. But even if you transfer two and it is a singleton pregnancy, there also risk has been reported. So best is if you can get a good single embryo and good quality embryo and transfer it, your results are going to be very good. So my conclusion is ART offers the best chances of preconception counseling, optimizing the ovarian stimulation and avoiding excessive exposure and handling of the gametes and embryos in lab improves the obstetric outcome. A good endometrial thickness is crucial to embryo development and preventing further obstetric complication. Single embryo transfer of a good quality embryo prevents multiple pregnancy and again optimizes the outcome. So friends, by failing to prepare, you are preparing to fail. So thank you very much for the patient listening.
Thank you, Dr. Bakshi, for your lucid and very elaborated presentation. Thank you so much. Now I would request Abha ma'am to kindly introduce the next speaker.
I take this opportunity to call upon Dr. Kavita Bapat, who is now going to talk on posterior reversible encephalopathy.
Before that, can we present certificate of appreciation to Madam Dr. Asha Bakshi, please? I'll request chairpersons to.
Next, as we all know, we have Dr. Kavita Bapat ma'am. Can I request our next speaker, Dr. Kavita Bapat ma'am, to please join us on the stage? I would request Dr. Meena Sawant ma'am to please join us, as we would like to listen to her. Apart from the academics, I know she loves dogs and she loves cleanliness because she's from Indore. Can I request our chairperson to please?
So, I welcome Dr. Kavita Bapat. We all know she has been the vice president of Foxy. She has been the organizing secretary of AICOG at Indore. She is running daycare, vaginal hysterectomy. She is a pioneer in vaginal surgeries. And these days we are getting her simple, useful tips every day. So,
thank you so much.
Best wishes for your future endeavors. And Dr. Kavita Bapat, please. A few words from Dr. Kumkum. She's asking.
Oh my God. Oh my God.
Oh yes, Dr. Kavita had specially requested me to announce that she's a lover of saris, and she's a lover of dogs, pets, and a believer in God, and that's and something else you said.
Thank you so much. Thank you so much.
Okay,
so
thanks.
Good morning, each and everyone. I am really proud and privileged to be at Patna. Patna is a place where I am coming from last 20 years. You will be surprised to know kabhi kis party, kabhi usme, kabhi usme, kabhi usme. And we people connect with Patna. Abhi timer mat lagana. We people will connect with the Patna because we are also a more female OBGYN like Indore and same at Patna. And the simplicity is really similar, almost similar with the Patna people and Indoris. So, love you all and for being here. And I really congratulate Dr. Alkaji, Meena and all the organizing, Abaji and Supriya, everything for having this Labourcon. I am telling you, this country needs more obstetrician than the fetal medicine people, genetic medicine people, IVF specialist, and then recent is the cosmetic people. Because each and every gynecologist should practice at least 20 years for the obstetrics, and then they should start doing many more things. That's my feeling. This country, we need to reduce the maternal mortality more. We have to do many more things in this country for the population control, and the Patna, Madhya Pradesh, this type of states, we need more. So I again congratulate each and everyone for having this type of conferences, which are more needed. Thank you so much. And again, Meena, you have given me the topic जिसकी पढ़ाई मुझे भी करनी पड़ गई. I have never seen, मेरे ज़माने में ऐसा कोई patient आता था तो लोग बोलते थे हवा लग गई है, आग लग गई है, पता नहीं कुछ हुआ है. So the topic is, can I start my topic here? दिख रहा है? अभी नहीं दिख रहा है. इसको चलाओ भाई. So, and another point, as being a contesting for the post of President Foxy, I tell you, a person from Patna to Patan, to Patiala to Visakhapatnam, everybody has right to become the president of Foxy. So that's the agenda and every member matters. So the topic, I think, is a posterior reversible encephalopathy syndrome and all these things. So I come from the city, which is the cleanest city, and real proud of that. This is a posterior irreversible encephalopathy syndrome, an increasingly recognized disorder, wide clinical spectrum of both symptoms and triggers, yet remains the poorly understood. While I was reading this subject, I also found out कि क्या-क्या ही पढ़ना पड़ेगा. So introduction is, it's a clinico-radicological syndrome. When we were students last 30-35 years, we have never seen this type of entity because we never used to correlate this type of things with MR, CT, anything like that. It's a rapid onset of symptoms, including headache, seizures, altered consciousness, visual disturbances, and known by various known previously. It's a reversible posterior leukophalaenopathy syndrome, reversible posterior cerebral edema syndrome, and reversible occipital parietal encephalopathy. And it's a truly treatable neurological disorder. So what actually happens? It is commonly not associated with acute hypertension. It's a clinical syndrome increasingly recognized and commonly because of improvement and the availability of the brain imaging. Again, I am repeatedly saying that previously we never used to get the brain imaging done, and that this is the latest syndrome you can say about it. It's a wide variation of the severity of the clinical symptoms. Number one, the blurred vision, even the visual disturbance are there, homonymous heminopsia, and a cortical blindness. Altered consciousness, it can be vary from mind confusion to agitation, and it can lead to coma also. Other symptoms include nausea, vomiting, brainstem deficit, and a seizures and a status epileptics are common. It's a non-conclusive status epileptus may be common than the generalized status of epileptus. This condition also indicates the poor outcome of the patient as well as the poorly not seen the patient properly throughout the pregnancy. So proper antepartum surveillance is very, very important when we get this type of patients, and for God's sake, we don't want this type of patients to come to us. It is strongly associated with the condition of chronic kidney disease, acute kidney injury, renal disease, hypertension, vascular and autoimmune disease, and exposure to immunosuppressant drugs. Organ transplantation, and therefore the important consider the PRESS to the differential diagnosis with the patient with renal disease and rapidly progressive the neurological symptoms. So what actually happens? It's just a pathophysiology. There is a hypertension and a central hyperperfusion. So two things happens. Either the hypertensive episodes, the pressure fluctuation, it can be renal disease, it can be autoimmune disorders. And if there is an endothelial dysfunction, cytogenic substance, preeclampsia, sepsis, and autoimmune disorders. It can be due to the chemotherapy or the immunosuppressive medicine. So two things are very, very important. We talk about PRESS. Number one is hypertension, cerebral hyperperfusion, and the second most important thing is endothelial dysfunction. This subject is more for the postgraduates and teaching students for this, but as a practicing OB/GYN, we also should know these are the few points are very, very important. So what actually happens? It's a theory one. There is an elevated arterial pressure. It leads to cerebral hyperperfusion. That causes the autocoagulation overcome and the BBS dysfunction vascular leakage. And another theory is there is a cytotoxic injury and there is a endothelial dysfunction. This all leads to vasogenic edema. So edema is the main reason for this. But we have to differentiate this patient from many more patients. Either there can be a central venous thrombosis, so we should differentiate it. Number two, it can be intracranial hemorrhage. There can be a posterior circulation stroke, and the primary central nervous vasculitis. I am telling you, when this type of patients come and a big list is there, though we don't know many more things, we don't understand many more things, but if this type of patient comes, it's our responsibility to make a differential diagnosis, write neurological opinion, when to send the patient to the neurological opinion and what to be done. So that's why we have to know many more things. Once again, Meena, for making me read all this. Then there's a non-vascular is the infective encephalitis, autoimmune encephalitis, and metabolic toxic encephalopathy. In last few days, I am traveling so here and there, and everybody gives me such a different topic. I feel क्या हो रहा है लोगों को लग रहा है सभी कुछ मुझे आता है. मुझे कुछ नहीं आ रहा है. मैं साधारण डॉक्टर हूँ, but I can study, I can read, I am a hardworking person. That's what I put it. A case one is a 35-year-old female brought to the emergency room, history of 3 episodes of generalized tonic and clonic seizures. Patient was referred from local hospital to the further management, and I am sure this type of tertiary patients which we receive sometime. Headache prior to the onset of seizures, patient relative revealed the patient had an unsafe abortion 10 days ago and later developed this thing. Severe fatigue, shortness of breath, and pedal edema. But the important point is, these type of patients should be taken care by the caregiver, whosoever there at a family, they should know all these things also, so they can bring the patient at the right time. Then due to severe anemia, she had anemia of 344, ongoing blood loss. Patient was transfused 5 units of blood in a local hospital. No history of hypertension, no history was available. On examination, all the vital signs are normal, but patient was drowsy, no obeying commands, withdrawals limit the painful stimuli, deep tendon reflexes were sluggish, and withdrawal response was seen on the plantar reflex. There were no signs of meningeal irritation, and the important point, all these laboratory investigations, because the blood was already given, but the important thing, she had a WBC count more, elevated C-reactive protein was there, and rest everything were normal. Then the coagulation profile and everything being done, but only increased protein level was there, otherwise nothing. But the most important point came when the ECG showed incomplete right branchial branch block, which can be there in many portions, but now the time comes of the MRI. This is a MRI based entity. Without MRI, nothing can be done in a posterior this thing, and that there is imaging showing a bilateral, occipital, parietal frontal cortex, subcortical white matter T2 attenuated inversion. Just to make it for all, इसको याद रखने की कोई ज़रूरत नहीं है. बस एक simple word is very, very important. That's a flare hyperintensivities. Because it's very, very important, T2 attenuated inversion. These are suggestive of PRES, and this is a confirmation for the diagnosis. Then encephalography showed a bilateral temporal occipital epileptiform discharge, and most important thing normally happens when we see this type of patient, we refer to neurology and the CT scan specialist. We say, "Wohi sab bata dega, hum to sirf sun le rahe hain." So these are the points, but we should know a few points about it. So this is the difference of the axial this thing. When we see there is a T2 flare hyperinsensitivities. When we see the matter of hypersensitivities, there is a bilateral occipital and parietal frontal cortex. Again, MRI brain is showing parietal frontal cortex, subcortical white matter, and there is a white matter hypersensitivities. And this is another thing which MRI which we able to, because patient when bring the patients of CT or MRI, we also have to raise it, or we just make all the acting of doing and seeing the CT, MRI and everything, but we should know also a few points, and that is, this is very, very important. A white matter hyperintensity is important. Now, this case, patient was admitted in an intensive care unit, managed with intravenous fluid, antibiotics, antileptics, monitoring of blood pressure, improved symptomatically from normal sensorium, leukocyte count gone down, vital signs normal, discharge after 7 days of the admission, follow-up after the first week eventful. Now, management is aggressive blood pressure management is very, very important. Withdrawal of offending drugs, and if there is a declampsia, we should say. No clinical trials evaluated the management of the PRES. Again, important point, there is very less over the no, there is no guidelines, nothing, but the rapid withdrawal of the trigger appears, hasten the delivery and avoid the complications. Anti-epileptic drugs should be used to treat the seizures. Anesthesia, ventilation should be instituted, and generalized status of epileptus to protect the airway. Corticosteroids theoretically improve the vasogenic edema, but there is no evidence in the use of PRES. Prognosis, anesthesia because poorly controlled seizures. Once increased the peritoneal dialysis and the anti-agents were commenced, the patient's clinical state improved and she rapidly recovered. Her clinical course is typical. Given the symptoms of PRES usually resolve within a week if the triggering condition is treated and the complications of seizures and edema are prevented. Again, the prognosis, MRI findings are reoperated in, this is Ogawa and colleagues have done, but radiological resolution can take weeks despite of most rapid delivery. So our concern is more important of the recovery rather than getting MRI and CT repeatedly again, because they are still there for the longer time. Persistent neurological deficit may be reported but are rare, and unlikely the patient with uncomplicated PRES, such as Ogawa's patient, will require a long-term anticonvulsant therapy. So anticonvulsant therapy, the steroids, all are very, very important, and recurrent episodes of PRES have been reported, particularly in the patient requiring dialysis, and therefore imperative to closely monitor the blood pressure to avoid the further this thing. So summarize this thing, I think I am making in a time. PRES should be considered in a patient who present with seizures, altered consciousness, visual disturbances, headache. It is associated with the chronic acute disease, solid organ transplantation, and use of immunosuppressive drugs, particularly in the context with acute hypertension. Typical MRI findings include reversible, symmetrical, posterior subcortical vasogenic edema. So vasogenic edema is very, very important for this. If recognized and treated properly, rapid onset of symptoms, radiological features, usually fully resolved within the days to weeks. So nothing to worry if this type of patients come, and if we are able to manage it in a proper time, we are able to this thing. Triggers are associated acute hypertension, kidney injury, eclampsia, sepsis, multi-organ failure are all is a big list, and they are very, very important, and the patient of organ transplantation will also be there. So these are the points which I am just love to depict in a manner of figures, because it gets the more impression, and these are the points. And then these are the typical points we should know about it, and I'm just putting it in the algorithm manner. Autoimmune disorders, steroids and the cytotoxic drugs, release of this, severe hypertension, and this is a picture, but very, very important to know there are sometimes macroabscesses formation. This is the algorithm which I always love to talk about, which I always love to spread the idea, because algorithms, right from artificial intelligence to the G-chat pad, everything gets impact into the mind fast rather than putting things. So the algorithm is a future. I am telling you right in everywhere. So these are the algorithm what to be done, and this is like that. And it's the last slide. we should be able to differential diagnosis. Press is whenever needed. Ghanti bajana mat, mera kaam ho gaya hai. So thank you so much. I am Kavita Bapat and my agenda is very, very simple. Every member matters. Every person sitting on the last right or person sitting Bhaskar Pal on the front row. Everybody has got the chance to become a President Foxy. Thank you so much. Support me and thank you so much. Love you all, Patna, for being with me.
Thank you, Dr. Kavita. Indeed, it was a wonderful presentation and you have spoken everything about press. Right from it being reversible, right from it affecting the vasogenic edema in the posterior lobe. Everything you have spoken very well and the message is well known that any patient who comes with seizures postpartum always think of press. Thank you so much.
Love you. Thank you so much.
And we'll just like to hand over this token of appreciation.
And since ma'am has finished 30 seconds in time, I would like to thank her because it always helps to be on time. Thank you so much. Can I request Dr. Vinita Singh ma'am to please join us. We have Dr. Anita Singh with us. Requesting Dr. Nibha Mohan, Dr. Supriya Jaiswal. Can I also request Dr. Bhaskar Pal sir to please join us. And the moment with Dr. Sadhna Gupta ma'am as well. Dr. Asha Bakshi ma'am, Dr. Madhuri Patel. मेरा मानो तो इनॉग्रेशन कर ही लो. Thank you so much. Can I request all of you to please look into the cameras? 3, 2, 1 and smile. You can definitely give a round of applause if you want to. Don't stop yourself. Thank you so much. With that, I would request Dr. Meena Sawant ma'am to please be on the stage as she's going to be the chairperson along with Dr. Kiranmai Devini. Can we have Dr. Kiranmai to please join us? Devinini, correct? Yeah. Dr. Kiranmai Devinini. Yeah. Now I got it perfectly right. We have our speaker as well. Can I request Dr. Madhuri Patel, who's already on the stage? And she's also told me, मुझे plaque मत दो ना, मुझे time ज़्यादा देना. So, hoping. Can I request our chairpersons to please invite Mukund, इनका CV डाल दे. Timing 19 minutes करना. Perfect.
Very good morning. Actually, this is a great privilege and honor to introduce our dear Secretary General Madhuri Patel Madam. We all know her. There is no need to formally introduce Madam. Madam is Secretary General Foxy, Joint Secretary Foxy in 2009 to Purandare sir. No, Madam is having some. So committee member FIGO preterm birth. She's Associate Editor, Journal of Obstetrics and Gynecology of India, Honorary Clinical Associate in Wadia Hospital, Parel, Mumbai, Honorary Consultant, Police Hospital, Mumbai. She's former professor and HOD, OB-GYN, ESIC, PGI, MSR, MGMH, Mumbai.
Thank you, Kiran. Thank you, Kiran.
You have multiple awards, but in one word, ma'am, you are very strong, stable, and a tough lady with a soft exterior who doesn't have any harsh words towards anyone. We love working with you. Welcome, ma'am. Thank you.
Thank you, Kiran, for your nice and warm words. Respected Chairperson, Dr. Meena, Dr. Kiran, and of course, you know, our President, Dr. Rishikesh Pai, Alka Madam, Vice President in charge of this conference. Then we have Dr. Abha Singh, Dr. Vinita, Pramila Madam, and all dear friends, Asha, Asma Madam, Bhaskar, Vinita, Sampat Kumari, and all my dear friends. Very good morning to all of you. At the outset, I would like to thank organizer for giving me this opportunity. My topic is very, very simple, but it is we all are facing this branch. So rising cesarean section rates are matter of concern. Cesarean birth is an unnatural method of a natural event. However, cesarean section can effectively prevent maternal and perinatal morbidity and mortality when used medically indicated reason. However, there is a substantial unprecedented rise in cesarean section rates worldwide, which is a major public health problem. At the same time, WHO also has said every effort should be done to give the mother who needs the C-section without starving the cesarean section rate. So let us see in the different countries what are the C-section rate. Dominican Republic, it is the highest, 58.1%, and if you see United States, it is 32.9%. So what about our Indian scenario? Union Ministry of Health and Family Welfare under the Health Management Information System, it was reported 23.85%. So look at the public sector. In 2008 and 9, it was 6.3%. It rose to 13.9%, double within one decade. Similarly, in private sector, it was 17.1% in 2008 and 9, and which became double in 2018-19 as 33.8%. So with the support of the World Bank, Government of India, Janni Suraksha Yojana was started, which was a cash incentive scheme in 2005 by establishing National Rural Health Mission. The implementation of this scheme resulted into the institutional delivery from 26% to 81%, and hence the improvement in the quality of care increased the cesarean section rate. It was also seen that education also matters a lot. In a low education, illiterate women, it was 6%, while the literate women, it was reported 33.6%. Similarly, wealth index, poor patient had 4.4%, cesarean section rate, while the wealthy women had as high as 35.9%. So this rising cesarean section rate is an epidemic. And what are the reasons? These are the characteristic changes in the characteristic of population. That with the environmental factor, we see more obese patient, multiple pregnancy with the IVF, ART treatment, and there is increased proportion of primary area coming to us at the late age, that is the older age. And non-clinical factors, we get worried all the time. Nowadays the young generation gets worried, they don't want to undergo labor pains, they are worried. Then we have also misconception that the cesarean section is safer than the vaginal delivery, auspicious date, generation shift in work and family responsibility. And of course, we have also shortage of manpower, medical legal issues, maternal requests, economic and social factors. So these are the non-clinical factors. So if you look at the clinical factors, these are really modified clinical factors which are responsible for the primary C-section, where we can really help to reduce the cesarean section rate. So these are labor dystocia, non-reassuring fetal heart rate, suspected fetal macrosomia, malposition, malpresentation, risk-adapted obstetric, and overuse of induction of labor. So is there a risk with the cesarean section? Yes. There is a 4-fold increase in the maternal mortality compared to vaginal birth. And even in elective section, there is 2.8-fold increase in the maternal mortality rate. Hawkins et al. Found that 82% in their series had a maternal death because of the anesthesia, especially general anesthesia. Then we also face the intraoperative complication like uterocervical and bladder laceration, blood loss more than 1 liter, and about 12 to 15 patients needed hysterectomy. Of course, the major complication increases as you take it patient for the emergency C-section compared to elective C-section. So post-operative complications are also major and minor. They are pelvic infections, sepsis, deep vein thrombosis, fever, urinary tract infection, wound infection. It forms almost 35.7%. So what about the babies? It is reported that up to 9% there are chances of baby getting injured by the surgeon's knife, and this is usually happens in a non-vertex presentation. Even if you even if you take the patient for an elective section, repeated scan, LMP, if you consider, still there are chances of baby having iatrogenic prematurity and hence respiratory distress syndrome. So now, what happens in the consequence pregnancy? subsequent pregnancy, the consequences are repeat C-section, scar rupture, hysterectomy, maternal and fetal mortality and morbidity increases. It has been reported with the single previous C-section, there is 1.7-fold increase in placenta previa, and with 4 and more, there is almost 9-time increase in case of placenta previa. So Zaki et al. Reported 60% rate of placenta accreta with 3 or more cesarean deliveries. And it has been reported that in US, the maximum cesarean hysterectomy is done due to placenta accreta. So dear friends, when we put a knife on the primary for the primary C-section, we have to be very careful because we are going to deal with this patient more and more with the placenta accreta syndrome. So we have to be very, very careful when we are doing a primary C-section. So other consequences are reduction of future fertility compared to vaginal delivery. It has been ectopic pregnancy has been also reported in C-scar, and there are big series coming up. And of course, scar endometriosis. That is also one of the late complication of cesarean section. So can we reduce this C-section? Yes, we can reduce, but not alone medical personnel. It is the combination, efforts from all medical personnel, healthcare, insurance industry, government bodies, we all can reduce the cesarean section rate. So we can do from the clinical point of view, especially clinical intervention in modifiable factors, indications which we are doing. So there is a ACOG, Society for Maternal and Fetal Medicine guidelines. They say for the labor dystocia, when you labor the labor dystocia, what guidelines they have given in 2014, that prolonged latent phase labor more than 20 hours in nulliparous women and more than 14 hours in multiparous women is not the indication for cesarean delivery. Cervical dilatation is considered to be in a 6 centimeter as an active phase and not as a 4 centimeter. Multiparous women should be allowed to push for 2 hours in the second stage and primary 3 hours in the second stage, and epidural anesthesia more than that, unless there is a fetal distress. And one should be very, very ready with the vaginal instrumental delivery to reduce the cesarean section rate. And for that, you require a proper training. So now, what about the induction? Because once you do induction and immediately you rush for the cesarean section. So failed induction is only should be diagnosed only after an adequate attempt which is defined as more than 24 hours with oxytocin. If possible, you can do artificial rupture of membrane, and with the contraction of uterus, if the cervix doesn't dilate, then we consider this is a failed induction. And therefore, selection of the patient. If the bishop is poor, you improve the bishop and then do induction of labor, then the success rate of the vaginal delivery will be high and it will reduce the primary C-section rate. It is also reported in Green Top guidelines of March 2017 that there is a role of external cephalic version which can reduce the breech delivery at term, and hence breech can be taken. This can cause a vertex, and you can prevent the cesarean section. There are some randomized control trials established that non-stress test has false positive value up to 99.8%, and this is associated with very, very high cesarean section rate. So it does not predict cerebral palsy. Category 1, that everything is fine, the baby is very good in condition. Category 2 is a non-reactive fetus to the physical stimulation, but it is not indicative that the baby is at jeopardy. Of course, category 3, tracing of recurrent late deceleration, recurrent variable deceleration, bradycardia and sinusoidal rhythm are the most justifiable condition for the cesarean section. So many times, during second stage of labor, because of the sustained contraction, you can find abnormal topography, cardiotocography, and there you have to be careful, you have to be prepared for the instrumental delivery and not for the C-section. So therefore, training of the instrumental delivery is very, very important. So let us look at the Indian scenario. Dr. Abhishek et al., in their hospital, what they did, this was a private urban hospital, what they did to reduce the cesarean section rate. In 2001, they found that in their hospital, the C-section rate was 79%. and they realized, they analyzed, and they thought that we should improve the quality of the assurance, and then they started analyzing, and then what they did, they hired a full-time salaried consultant and began regular audit on cesarean section. But still, this was inadequate. So what they did, they joined an improvement collaborative in 2011 and dedicated resources for quality improvement, which included adopted practice guidelines, monitor outcomes by consultant, improve labor ward support, strengthen antenatal preparation, and move to group practice among consultants. So what were the results? The guidelines said that you should admit the patient only when she is in active labor. And when they admitted patient in the active labor, it reduced the cesarean section rate for fetal heart rate abnormality from 23% to 5% and delayed progress from 19% to 6% in a low-risk primary gravida women. Antenatal preparation also increased the trial of labor from 28% to 79%. Group practice reduced the time, pressure, and the stress with a decline in C-section from 52 to 18% and low-risk primary gravida from 48% to 12%. And similarly, they continued this and they could reduce the cesarean section rate in 2017 and 2018. Of course, certain intra-peripartum problems were there, like a PPA, third and fourth stage, degrees test, shoulder dystocia, Apgar less than 7 at 1 and 5 minutes. But these are, comparable with other vaginal delivery. So they could reduce the cesarean section rate. Now, WHO recommends that non-clinical intervention is there. What are they? There is, you can give the alternative in reimbursement model for doctors and hospitals which favor vaginal delivery. Equal amount should be paid to the C-section as well as vaginal delivery, especially our Janani Suraksha Yojana. Educational intervention for the women and families. Decision making, a mode of delivery. Be pre-informed to family member, use of clinical guidelines, intervention with multiple components, mandatory second opinion for cesarean decision, audit of cesarean section, and timely feedback to the health professional, and midwife-oriented care and midwife obstetrician model. So these are the non-clinical intervention. So now let us look the challenges to keep C-section rates low while maintaining safe outcome for the mother and infant. This requires continuous auditing of the C-section. Robson classification has been proved that this is one of the best methods to keep auditing of C-section. There are many systemic review as well as WHO recommend that Robson classification is good to monitor the C-section. So these are the 10 Robson 10 criteria group classification, which I am not going to go into detail, but let us see what has happened. Boetti et al., they had taken a citation of 385 articles. 30 were assessed for full text review and 6 studies were identified. This was the first systemic review from the 6 studies focusing on the Robson classification to categorize and analyze data on C-section rate within clinical audit cycles. So in Brazil, what they observed, what they did, they audit and feedback intervention where monthly report of Robson classification tables were distributed, discussed with clinical staff. During the 10-month intervention period, the C-section rate in Robson group 1 and 2 together showed a decrease from 34.6% to 13.5% without compromising the perinatal outcome. So only by discussing, only by, talking to each other and where we are, going wrong or going, very well, we can discuss and they could reduce it, to 13.5%. In Sweden, they describe a 9-item list of organizational and cultural changes introduced along with training to reduce unnecessary intervention, including C-section. And they could reduce, what they did, they used to identify the target group term, nulliparous women in spontaneous labor, that is group 1, and to provide feedback to staff on monthly basis for all term multiparous women in group 1 and 2. And they also started the other intervention. And following this, what they reported, the group 1, they could reduce the cesarean section rate from 10.1 to 3.1 from, that is in 11 years. So this is a very, very commendable job. And then Italy, they again, the strategy included daily feedback and discussion with the staff during the intervention phase and other non-clinical and clinical component. The authors reported that statistically significant reduction in C-section occurred in group 1 to 4 from 17.2 to 10.3% within 6 months. So the Robson, the Boetti has concluded the Robson classification allows standardization comparison of C-section rate across time and setting and the prospective identification of specific groups of women which most contribute to the overall cesarean section rate. This makes the Robson classification an useful tool within the audit and feedback cycle to reduce cesarean section rate. Now let us look at from our angle, our paper that is in 2020, Srinivas Gadappa, they also used this Robson classification and they could reduce the C-section rate from 33% to 26.9%. And they found the maximum group, that is group 5 of cesarean section, had a largest contribution, that is 36.9% had a previous cesarean section, but the contribution of the repeat C-section and modified induction protocol could reduce the primary C-section rate. And therefore, there are many studies happening. Now there is a Jacob KJ et al. They did a modified Robson classification where they included all the cesarean patients in group 8. And what they found that, they found that all women with previous were classified into separate group number 8. A total of 1,337 women deliver. Out of this, 924 women deliver vaginally and 413 women underwent cesarean section. See, the cesarean section is 30.8%. So why it happened? Because there were 270 women in group 8, all previous section, which is approximately 21% of the total labor cases, delivery cases, and out of which 254 underwent repeat C-section. So it is almost 91.3% of previous section underwent C-section, and therefore it gave overall cesarean section rate was 61.5%. And total trial of labor after C-section was hardly practiced, and this requires, really training. In the remaining 1,059 women, 159 underwent primary C-section rate, which was 15%. And that was more attributed to induction of labor, that is 30.8%, and without inducing, just taking for a section pre-labor, 16.3%, and primary gravida, 11 with breech, 11.3%. So strategies to reduce primary C-section, to improve case selection for labor induction and pre-labor cesarean section, which can reduce the primary C-section, increase use of external cephalic version.
19 minutes pura.
Okay, I'll come to the conclusion.
Yeah.
I'll come to the conclusion.
जैसे आपने बोला था वैसे. Okay कर दो.
I'll come to the conclusion, 1 minute. So rising C-section rate is a matter of concern because of the high maternal and perinatal morbidity and mortality compared to vaginal delivery and also in the subsequent pregnancy. The clinical tools for auditing is a quality improvement process. Analyzing and implementing the clinical and non-clinical modification can tremendously reduce the primary C-section rate. Robson classification is ideal, but modified Robson classification can be implemented according to your need. Up to 91.3% are cesarean due to repeat C-section. Hence, by reducing primary C-section rate, it is possible to reduce C-section without compromising mother and baby. Thank you very much for giving me.
Thank you, ma'am, for that wonderful critical appraisal and putting things in the right perspective. Before putting in the knife, just to think whether it is really needed for the baby and the mother and auditing the right way ahead. Thank you, ma'am, for that wonderful presentation.
Thank you. I would request the chairperson to please present the token of appreciation to ma'am. And as I would like to save time, can I request the chairpersons for the keynote address to please also join us on the stage? Can I request the chairpersons, Dr. Usha Sharma, Dr. Abha Rani Sinha, and Dr. Nibha Mohan to please join us? know what to do. तेरे पास कन्वर्टर है क्या?
Good morning. Now we are going to start the keynote address. And as a speaker, we have none else than Dr. Bhaskar Paul from Kolkata. Now, we all know him, but some of you who do not know him very well, I am going to read his short biodata. He is a senior consultant obs and gynae at Apollo Gleneagles Hospital, Kolkata, Chair AICC RCOG, immediate past President IAH, Foxy representative to Suffolk, immediate past President Bengal ONG Society. He is going to talk on cesarean section in the second stage, which is taxing for all obstetricians, and we all have to face it. He is a very learned and experienced doctor, and is going to tell us maybe something new what we should be doing in the second stage cesarean section. Please start with your deliberation.
Thank you, madam. It's always a pleasure to be in Patna and among friends. And as I said that week, I keep coming to Patna since 2005. But the Patna society is really transformed since the AICOG of 2014. It's a much more vibrant and younger society now, and led by a lot of dynamic women, So it's a pleasure every time we come to Patna. I think Madhuri set the context, and Madhuri spoke about economically better off women having a higher cesarean section rate. In England, we used to call them too posh to push. But the fact stands that cesarean section is very common, the commonest operation performed across the world now. And the moment we strive to reduce cesarean section rates, what would happen is that the number of cesarean sections that happen in the second stage would increase. At the present moment in India, we see much less second stage cesareans compared to the Western world, where they would not quit, as Madhuri showed, that at least 24 hours of oxytocin in an induction before they quit. So there's a much more second stage cesarean sections. And it is challenging. I bring you greetings from Kolkata, and I hope most of you who attended the AICOG enjoyed it. The problems in cesarean section in second stage, the challenges are, number one is with the delivery of the baby. Now, more often than not, the head is deeply engaged, there is no liquor, and it is a big baby. And as a consequence of trying to manipulate and taking the incision in the wrong place, you have an extension of the uterine incision, which tends to be lateral, inferior, or the worst is inferolateral. And many a times the incision that is taken on the vagina. Because of a long labor, because of a traumatic cesarean, the incidence of hemorrhage increases, which is either torn or trauma, or if persists, then it can actually be a coagulopathy. There is a risk of ureteric injury when there is an extension, and of course all this adds to increased morbidity. Now, what we need to understand is whenever there is a second stage cesarean happens, we need a skilled obstetrician and we need a neonatologist present at the cesarean, because at the present moment, not all elective cesareans do have neonatologist to stand by, but here we need a neonatologist. We need to make sure that the patient is not anemic, and if this is anemic, that we have arranged blood products as appropriate. We need to try to ascertain the position of the fetal head. Sometimes it is difficult. There are units now which we are using an ultrasound on the labor ward to try and make out what is the position of the baby. And the consent needs to address the fact that there are risks to the baby and the risk to the mother. Now, the most important point is, where do you take an uterine incision when you are doing a cesarean section in the second stage? Our teachers taught us that you take it around 1 to 2 finger breadth above where you would normally incise. And I always found that that was a very silly way of portraying, because everybody's finger breadths are different. And every time you're possibly not taking the cesarean section, not taking the incision at the same site. So ideally, you need to have an objective way of deciding where you take the incision so that you don't go in the vagina. And the objective way is to identify the upper edge of the loose utrovesical peritoneum and make the incision just below the upper end of the loose UV peritoneum. That will make sure that you are not going into the vagina. The second way to prevent an inferolateral extension, which is easier to prevent than manage, is to curve the end of the incision upwards towards making it an U. In which case, that if you have an extension, the extension will only go into the uterines. And as gynecologists, we well know how to manage an uterine extension into the uterines. So it's a good idea to practice making an U or a smiling incision in every cesarean section. And most importantly, it is an adequate section. When we were postgraduate students, we used to take great pride in how small each one's incision was and how quickly we finished a cesarean section. But at the end of the day, I think as you get more experienced, you get wiser, and you need to understand that there are situations where you need an adequate incision, and second stage cesarean is one, and poorly formed lower segment is one where you need an adequate incision. Now, how do you deliver a deeply engaged head? The traditional way has been to push the baby from below. Now, what is important is not to fight the fetus, which means that do not manipulate the head when a contraction is going on. This is when it is stuck, this absolutely badly stuck, where you need to break the vacuum gently. And having steep head down helps. And as you are manipulating, you can hear the air entering between the head and the pelvis, and you hear a sound like a sloop. Some people administer tocolytic, and if it is available, you can use a terbutaline 125 micrograms subcutaneously, and ask the assistant to push the head from below. And the assistant should insert the hand in the vagina before you started painting and draping, and not after you are struggling. Do not use the single blade of the forceps as vectis. This is something which is written in textbooks and copied in textbooks generation after generation. It is not only illogical, it is potentially dangerous. You can, if you can manage to bring the baby's head up to the level of the incision, you can apply a proper forceps, but not a single blade as a vectis. I have no experience of the fetal pillow, but there are several centers in India who trial this, including a center in Bombay and Arjikot Medical College in Calcutta. This has a foldable silicone base. I'm proud to say that this was invented by an Indian in UK, Dr. Rajiv Verma. A foldable silicone base with a rounded edge and balloon. It has a 100 centimeter tubing with a 60 ml syringe, and you need around 180 ml of normal saline. And what you do is you fold the pillow and you put it under the head, and then gradually insert it, holding it in between the thumb and two fingers, and sometimes like inserting a folded vaginal pessary. And this is how you put it, and then you gradually fill it, and what it happens is it pushes the baby up. There is a randomized, multicentric randomized control trial, as I said, several centers in India participated in that, which looked at the elevation of the fetal head with a fetal pillow during cesarean delivery at full cervical dilatation. 120 women were assigned to each group, and the primary outcome was incidence of major uterine wound extensions, which is a grade 2 or grade 3 extension. And they found that the incidence of major uterine wound incision was significantly lower in the fetal pillow group than in the control group. What is important is to have drills for second stage cesarean section, and pillow is included in the RCOG operative birth simulation training program. But being Indians, I think many of us actually should move off for Patwardhan's maneuver. Now, it is something that has come from India, and later on there are people across the West trying to popularize as the reverse breech extension. And Patwardhan's maneuver is practiced routinely in some hospitals in India, but not in all hospitals. And that is why I think Madhuri comes from JJ, I come from Sion, and we were routinely trained to do a Patwardhan's maneuver. And that is when first time I used a Patwardhan maneuver in UK, like at the perinatal meeting, the pediatric lecturer said, I don't know what he did, but he did something like a magic and the baby came out very easily. Now we need to understand that people talk of Patwardhan's maneuver and modified Patwardhan's maneuver. If you read Dr. Patwardhan's monogram, there is nothing called a Patwardhan's maneuver and a modified Patwardhan's maneuver. There are two Patwardhan's maneuver, one is for back anterior and one is for a back posterior. And that is what we need to understand. Now, I have already said that in second stage cesarean section, the baby's head is down and you are making an incision up. So if you made the incision at the right place, you should be coming at the level of the shoulder. So irrespective of what you do, the first thing that you will take out is going to be an arm. Please remember that. Now how it differs is that in the back anterior, you need to make sure that you keep the back anterior and you deliver one upper limb followed by the other upper limb. And then you keep on applying fundal pressure and then you deliver the fetal back. It's like a reverse breech extension, a reverse extraction. And then the abdomen and then the lower limbs and deliver the head last. This is a video of that. This is a video taken from Sion Hospital by the residents in an emergency. You will see that they will struggle with the incision. They should have taken a little bigger incision. And once the baby's arm is out, actually the Doyens needs to come out. So you will see that this is a back anterior. So after making the uterine incision, you need to put your hand in, follow the shoulder and get the arm out. Once you get the arm out, ideally you should remove the Doyens and then look for the other arm. Once you got the other arm, then just like a reverse breech extraction, you hold it with two hands and gradually advance your hand to get the trunk out. And this is the stage where you will need fundal pressure, good fundal pressure. As you can see that these are always big babies, so a little bit of bigger incision would have helped. So this is the Patwardhan's maneuver for back anterior, and this is not a modified Patwardhan's maneuver. So nicely, this is as I said that a little bigger incision would have helped. That is the only criticism here, and then the legs come out and the head comes out last. And this is actually now found its way. We have popularized the Patwardhan's maneuver to the UK. We've taught it to the Bristol team, and now it has gone into the Moyes manual. And if you look at their obstetric skills manual, it now has Patwardhan's maneuver. Now, there's a different in when it is back posterior. When the back is posterior, what you will do is that it is always a little bit of oblique. So it is very difficult to find the other upper limb. So what you should do is, as usual, one upper limb will come in, and then you will go search for the ipsilateral lower limb and get that lower limb. Then you deliver the other leg, then you apply the fundal pressure, then you deliver the abdomen, and then the other arm, and then the head last. This is a little more difficult than the back anterior. The back anterior tends to be slightly easier. Here the trick is to find the ipsilateral leg. Once you find the ipsilateral leg, then it becomes a cakewalk. So this incision is adequate, so the baby comes out well. So again, as I said, that this is the way that the Moe manual talks about that. The next I come to extension of incision. Now, as we said, that extension of incision is easier to prevent, and how do you prevent that? You prevent that by making incision at the appropriate level, height, and you make a smiling incision or a C-type incision, curving it upwards. If an extension happens, many people exteriorize the uterus at cesarean section. Now, this is a lot of debate. I will not go into the debate, but if you are not into the habit of exteriorizing, this is where you must exteriorize the uterus. Exteriorization helps in several ways. Number one, the upward traction reduces the blood loss. Number two, ureter falls back. Next thing we need to do is ensure the bladder is sufficiently down. It is important to control the bleeding first. We need to think about the ureters, but the priority in trying to look for ureters and not suturing, because I can't identify the ureter, we cannot let the woman bleed to death. So the priority is in hemostasis. Now the point is, many a times you will not be able to see the lower angle of the extension. What you do is just like an episiotomy. What were we taught, that if the episiotomy, you cannot see the apex of the episiotomy, suture wherever you can, then pull that down as a stay suture and gradually move up. Similarly, here you place your sutures under vision, start sutures where it is visible, keep the thread long, then pull it up, use it as a stay suture, and gradually you go down. And suture the apex only when the apex is visible. Always use a pelvic drain and use a wide bore tube drain and not a suction drain. Because a suction drain, what will happen is that the momentum will sit on it and it will get blocked very, very easily. Now, these are the patients who are prone to hemorrhage at cesarean section. And what is important is that two things I want to talk about are the uterine compression sutures and the uterine artery ligation and the utero-ovarian artery ligation. I think it is mandatory that postgraduates leave the hospital with an MS degree and only after learning at least one form of compression suture and the uterine artery ligation and utero-ovarian artery ligation. These are very easy to learn, and this can save lives, and this can buy you time till help arrives. That is why I will talk about only these things. Now, uterine artery ligation, what you do is you take your bite from 1 centimeter medial to the lateral edge of the incision at the level of your incision and take it out posteriorly, and then leaving the round ligament away, you tie it on both sides. But only doing the uterine artery ligation will not help. You need to do the utero-ovarian artery anastomosis ligation also. What you do is you lift up the tube, put your needle from the avascular area just below the tube, include the entire leash of vessels, and go below that again from an avascular area. You take out your needle and you tie that. And our experience is that this is something which we were postgraduate students. Dr. Daftari used to propagate a lot and say that do the uterine and utero-ovarian ligation together before you move on to compression sutures, which hadn't become popular at that time. Now, I am not a fan of Belin sutures. The reason I am not a fan of Belin sutures is, number one, it is complicated. You need to make things simple because your brain doesn't work when you are in an emergency, especially if you are young. So you need to teach things which are easy. Number two, it necessarily needs a uterus which is open, which means if you close the cesarean wound, or if you are doing it for an atonic PPH following a vaginal delivery, you cannot do that. Third, there are anecdotal reports of uterine necrosis following Belin sutures. So, of course, it is life-saving, but the reason I prefer it is because there are the Heyman sutures. Ideally, they should be called the Arul Kumaran sutures, but Heyman was Dr. Arul Kumar's senior registrar at that point of time when he invented this. And what the Heyman suture does not require opening of the uterus, it is much simpler. And what you do is that just you go above the bladder reflection 2 centimeters medial to the lateral end of the uterus and put a suture from front to back and tie it at the fundus, and you do it on both sides. And this is a pictorial diagram of that. If necessary, you can take a second state of Heyman sutures too. Now, one word of caution. To know whether a compression suture will work or not, what you need to do is before you put the compression sutures, you compress the uterus and ask somebody to inspect below whether the bleeding has reduced. If the bleeding has reduced, only then your compression suture is going to work. And this is again a video of the Heyman suture that again comes from the Sion Hospital emergency. You take the needle, ideally these should be done with number 2 catgut, which is no longer available, so use a number 1 Vicryl and take it out posteriorly. And what is important in compression sutures, when you are putting the knot, do not put it at one go. Gradually keep on tightening it. Gradually keep on tightening it. The uterus will compress better. So take 2 or 3 attempts before you tighten your first knot and put your second knot. That is a very important thing. And as I say, that I think it is not imperative that someone goes out of MS knowing how to do an obstetric hysterectomy safely or how to do an internal iliac ligation safely. But they need to do how to put at least one compression suture safely, and they need to know how to do the uterine artery ligation and the utero-ovarian artery ligation safely. Because by that time, seniors would arrive. You bought in at least half an hour, and 90% of cases, we will actually be able to manage with this. But if you need an internal iliac ligation, then what you need to expose is the lateral pelvic wall. And one important point is, the problem in internal iliac ligation is the external iliac vein. That is one which is easy to injure. That is one which can cause catastrophic hemorrhage, very difficult to manage unless you have a vascular surgeon in your same hospital. And the easiest way to avoid that is to go from lateral to medial. And finally, assess blood loss accurately, assess the need for thromboprophylaxis. Our maternal mortality has come down to near 100 now, which means that you've conquered hemorrhage, we've conquered infection, we've conquered hypertension to a great extent. Now, the thromboembolism deaths are going to stand out. The women who have a delivery 3 days later just go to the toilet and drop dead. So assess the need for thromboprophylaxis. observe the patient very well, document everything, and explain everything to the relatives. In an emergency, we sometimes do not have the time to explain because saving the life takes precedence. And I will end with a quote from Ian Donald, exactly 19 minutes and 10 seconds, Nikhil. Over a long clinical lifetime, one tends to forget or take for granted one's successes. It is the failures which stand out like keloid scars, never to be forgotten, and hopefully a warning to others. I have to recognize if there is any classic mistake which I have not myself made, it is simply because of the lack of time in which to commit it. I think it is important that to understand all of us have made mistakes, but you become a better doctor only if you learn from your mistakes and do not repeat the same mistake. Thank you very much.
Thank you, Dr. Bhaskar Pal. It was indeed a wonderful presentation. Where we all know that second stage cesarean section is a difficult thing, increase with both maternal and fetal morbidity as well as mortality. There are lots of problems and you have tackled all of them, like the incision, where to give the incision on the skin, where to give the incision on the uterus, how to deliver the baby, how to combat hemorrhage. I think you have dealt everything very well. But I think there's one point I would like to say, that we need to reduce this second stage C-section by bringing out experts in instrumental delivery. Because we have to bring down the rising rate of C-section, as Dr. Madhuri Patel has spoken in the morning. So I think that point also has to be kept in mind. So thank you so much, Dr. Bhaskar Pal, and Dr. Nibha, please.
Thank you, sir. Thank you for the brilliant talk. And Patwardhan technique which you mentioned, I think it's much, much better and safer than pushing from below and taking out the baby. I find it much easier and much comfortable and less complication. And thank you for mentioning all those. So now it's time to felicitate Dr. Bhaskar Pal with certificate of appreciation.
Thank you so much, sir, for finishing it in time as well. At the same time, we would like to move to UNICEF session, and for that, can I request the chairperson, Dr. Barun Kalasana, Dr. Veena Pandey, Dr. Dharmashila Sharma to please join us on the stage. To save time, can I also request our first speaker, Dr. Sarita Simba, to please also join us on the stage. The time allotted for each speaker is 15 minutes, and I hope it's going to be enough because we would like to keep it on time. I would also like to thank and acknowledge we've got our Foxy President, sir, Dr. Rishikesh Pai with us. Thank you so much. And he's also uploading his talk, and he's also going to be ensuring that it all goes on time. Thank you. Requesting Dr. Sarita Simba ma'am to please join us on the stage. Again, a kind request for Dr. Sarita, if you could join us on the stage. Dr. Sarita is here as the State Program Officer, State Health Society of Bihar. We would like to thank her for being here. Can I request the chairpersons to please give the go-ahead to get started? We are ready, she is ready. And can I request the audience to kindly be seated? Chairpersons, okay? Yes. Madam is ready? Yes.
Good morning.
चालू है मैम चालू है
Hello. Good morning to all of you. At the very beginning, I would like to thank the organizing committee to give all of three a chance to be the chairperson of this important scientific session. The first speaker is Dr. Sarita Sinha. She is from
State Health Society, ma'am.
She is
Government
from
of Bihar,
UNICEF.
yes, ma'am. No, ma'am, State Health Society.
State
Health Society. State Health
हाँ 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 ठीक है.
Yes, we can get started, ma'am.
You
Please.
start.
मेरा PPT है कहाँ? Thank you, madam. And thank you, Foxy, for giving me opportunity to speak on a very important topic, that is improving quality of care in maternal health. And this is the area where I actually work also. So there are so many programs under this improvement to improve quality care in maternal health. I think everyone knows these days about Lakshya, and private facilities are doing Manyata, I think. But in government facilities, we are doing Lakshya, and Lakshya is actually doing some quality care in labor room and maternity OT. These two departments are actually taken in the Lakshya, that is NQAS certification only. NQAS is National Quality Assurance Standards. And next, and one another is Suman program. So I'll talk about each and every program one by one. So this is my presentation outline is overview and what is the scenario of maternal health these days in Bihar and various quality initiatives which we have taken. Surakshit Matritva Aswasan, that is Suman, is a short form is known as Suman, midwifery initiatives and way forward. So Bihar has, right now the population is 12.49 crore, and out of this 34 lakhs pregnant women are there, and near about 30 lakhs live birth happens every year. Government of India has adopted RMN-CHA framework in 2013, which came as NRHM, I think first, then it became NHM, that is National Health Mission now, and it aims to address all major causes of mortality and morbidity among women and children. So despite there is reduction in MMR, Bihar still contributes to 15% of India's maternal death. Right now the Bihar MMR is 118, which has come down from somewhere, I just show you the graph, I think it's now 118 per lakh live birth. It was just 2 years back, it was 130, and it was 149, I think, 6 years back. So it is coming down, but the rate we are actually falling is not that satisfactory, or we should not be that happy that still we are going down, but we need to improve more and more. And here how to do it? Because if we want to improve our maternal mortality ratio and we want to go down, we have to work more. We have to think, actually once it started falling, it was falling like anything, because we are doing something and where we are doing some improvement in facilities in our public health hospitals. But right now we have to do more and more, so the quality is here. The quality is a key to improve our health scenario in maternal health. So the background is Bihar maternal mortality, though it has come down, but we have to long way to go in terms of ensuring healthy lives. So we are committed to reduce up to 70 per lakh by 2030. So 2030, the aim is 70, but we need to improve this so that we can come down to 70 before 2030, not we should wait for 2030. So what we are thinking, no, we should be improving like this, that at least two-digit figure should be before this 2025. So we are in 2023. Next year, by next year, it should be 70 per lakh. It should be at least two-digit, less than 100. That is our aim.
And now with the help of you, all of you, I think we can improve that much. So the rationale is that quality of care halves the maternal and newborn death and stillbirth. What is the data says that once the woman enter in labor room and when she exit the labor room, that is the time where the 46% deaths occur. Most of the maternal mortality time is that. So if we can improve that area, that is the entry of labor room to exit of labor room, and during that period if we provide all quality care, each and every step is given with the all kinds of quality like trials, and after trials we are giving them proper the antenatal care is different, but this part is, that's why the Lakshya has taken this part. And the WHO framework says the health system in quality care, provision of care and experience of care. There is evidence-based practice for routine care and management of complication, actionable information system and functional referral system. Experience is effective communication. We can do communication with the patient in a very effective way, and respect and preservation of dignity and emotional support. These three are actually another pillar that is the part of Lakshya right now, that is which was not taken care initially. Now we are taking care of this area, and the competent and motivated human resource and essential physical resource that is available. That infrastructure should be good. Now we can see everywhere in all hospitals in Bihar, I think we are finding a good labor room. Earlier it was labor room is the most neglected part of the hospital. Now it is, I think, everywhere if you go in any hospital, you will find the labor room is the most beautiful part of the hospital. Everyone will say that, okay, the labor room is the best, but other departments should work more and more to improve their services. And individual and facility level outcomes are coverage of key practices and people-centered outcome, and that becomes the health outcome. So this initiative, this quality of care, actually half the maternal, and that's why it is said that the quality of care halves the maternal and newborn deaths and stillbirth. So our target is what I said initially, that MMR is 118, this is current status, but we want 100 by 2020 it was target, but I don't know if SRS said after next year I think SRS will come. If it is, but due to COVID we are apprehensive that whether it will come as 100 or not, but if it is 100 we'll be really happy. And neonatal mortality should also come down like that, because the neonatal mortality is always related to labor room practices. And I was just stated initially that the highest risk day is day 1. That's why this Lakshya program has come. And this the birth is the time of greatest risk of death and disability. Maternal and child mortality concern and solutions are like reducing maternal and child mortality is a key priority for improving population health outcome, for achieving health-related sustainable goal, and ensuring quality care with provision of assured delivery of services with respect and dignity to woman and her infant with impact and outcome hugely. To meet the requirement, GOI has launched Lakshya and Suman. These two programs are quality care programs which we are running under maternal health these days. And just tell you about few lines about both the programs. One is Lakshya. Lakshya objective is to reduce MMR and newborn mortality and morbidity, to improve quality care during delivery, immediate postpartum, and stabilization and complication, ensure timely referral, enable an effective two-way and follow-up system. And third is objective is to enhance the satisfaction of beneficiaries. Lakshya you will not get Lakshya certificate unless the 80% of the beneficiaries are satisfied with your services. So this is the feedback of the beneficiary who are actually receiving your services. If they say yes, the behavior was good, they said yes, they respected us, they did not scold us, they did not beat us. These are the also important thing, because they remember all these things when they go back home. So the dimension of Lakshya is about improving this quality of care around birth. So maybe I am repeating some lines one by, but actually it is necessary sometime. So quality certification of labor room and OT through existing assessment process, that is NQS, a National Quality Assurance Standard, is Government of India initiative. And this is ISQA certified standards, that is International Standard of Quality Assurance Standards. So which is actually, madam, these are ISQA certified is international certification. You must be knowing that in private hospitals you used to get sometime NABH, or some bigger hospital has JCI and other kinds of certification. So every hospital need to have one certification so that you can say that is assured services are given. In India, for public health facilities, we are providing NQS certification. Lakshya is NQS certification for 2 departments. So, so here attainment of 75% facility level targets and satisfaction at least 80%, not less than 80%. If it is less than 80%, Lakshya is not given. And this is always independent. We are taking independent survey of the patient and then we provide this. And all government medical colleges are there for Lakshya right now. We are working on it, and all district hospital equivalent health facilities, all designated FRUs are under this. And these aspirational districts are definitely on priority. And in Bihar, actually the first labor room which was certified was in aspirational district, that is Purnia. We started from aspirational only. So this is the committee and group arrangement, national level, ministry and NHSRC, national mentoring group, state level, state QA committee, that is quality assurance committee, and state mentoring group, and district level, district committee, coaching team, and facility level. But in Bihar, actually, we have added one more committee that is known as regional committee, because the 9 regions are there in Bihar, so we are working like that. So the criteria is the same. The money which is given every year, if it is medical college which is certified for Lakshya, 6 lakhs per year for one labor room, and if OT is also certified, both are 6 lakhs. And if it is district level hospital, 3 lakhs each, and if it is SDH or CSC level, 2 lakh each. These are the system, actually maybe not very much interesting for you, but actually these are the area of, we divide it into area of concern, like service provision, what are the patient right, and in every area of concern we actually find some measurable element, and where we measure you that whether you are doing it or not correctly. So there are 8 areas of concern. The first is service provision, second is patient right, third is inputs, like every equipment and infra should be there, a doctor should be there, these are inputs. And fourth is support services, like every hospital should have better support services like security, food, and all these things. And fifth is the most important, which is much more interested, maybe you people are more interested in that, that is the clinical care. And that is the longest checklist it has, because clinical care is most important. Here everyone should be skilled properly. So there are some more checkpoints to measure the skill of the doctor and the nurses as well. So OSCE are going on every time. You have to do OSCE, then you take a gap. If there is some gap about some skill, then train them once again, and then again do a OSCE. This process should go on. And then infection prevention is very important. If there is no infection, then only you would like to work. And ultimately the quality is quality, so the quality measurement tools and all are used here. Some quality jargon language are also used in quality people. And the last, not the least, is outcome indicators. So these are the things. So the colors are also like that, only given. So one is standard. So these are the area of concern. In Lakshya, in 6 rapid improvement cycles are there. Real-time partograph generation, usage of birth checklist, surgical safety checklists, strengthening document practices for generating robust data for driving improvement. These are the 6 up. You can take it in 2 months. You can take it three or four rapid cycle at one go. That you have to decide, and every hospital can decide on their own. How can they go on for this 6 rapid cycle? Presence of birth companion. This is also given by rule. Actually, we have given a letter and we have issued some guideline for also for this. In Bihar, actually, the Prasav Sakhi. Okay, for 2 minutes only. So Prasav Sakhi actually been allowed here. She should be a married woman who can accompany the pregnant woman inside the labor room, and she has some do's and don'ts also. Then assessment, triage and timely management of complication, management of labor as per protocol during active management of 3rd stage of labor, rational use of oxytocin. This has also improved the rational use. Only this step has improved the birth outcome like anything in Bihar. I think all the hospitals right now, they are not using pre-delivery oxytocin easily, but an essential emergency care.
Really sorry, ma'am, but the time is up. If you could come to the conclusion slide, that would be really...
I am going to the conclusion slide. So these are the activities. I think I was spoken more than the time. Time is up. So this is the last slide, I think. We have done Mission 60 recently, and now the input part has been done. These are the milestones these were the hospitals pre and before. Before and after, you can see improvement in our different hospitals right now in Bihar. Suman, I don't think I have time to speak on Suman, but Suman has Suman is not a new program. All programs under this umbrella right now. And so under this program, madam, as I will only say in the last line that 9 departments are being taken, which is actually working around our pregnant woman and newborn, like OPD, IPD, labor room, maternity OT, blood bank, and NRC, pediatric OPD, pediatric emergency. All these are being taken, 9 departments. If we can certify all 9 departments, we are done with Suman. Thank you, madam.
Thank you very much. Can I request the next speaker to please join us?
Thank you, Dr. Sarita, for ensuring our mothers for proper care. I hope the maternal mortality rate will come down soon. Thank you very much for brilliant presentation. I invite Dr. the second speaker.
Yes, ma'am. Please, I think... ऐसे नहीं करो, वो है ना, रुकेगा मेरे लिए.
I welcome Dr. Reddy, the health specialist UNICEF, for his presentation on bridging community with health care facility. I hope that may be the key of success in maternal care. Thank you very much.
Thank you, madam. Respected chairpersons in the dais and also my respected dignitaries of the dais. I would like to thank Foxy for organizing this Labourcon with the theme that Swasth Nari and Sukhi Nari, which is very much aligned with the UNICEF's mandate principle and also Health Department's mandate and principle. So I am glad to be here and thank you for inviting us to present a session on Labourcon. So thank you very much. Actually, previous speakers, they spoke about the facility-based initiatives, but actually I will touch here upon the community-based initiatives and also the linkages between facility and community-based services. So we know that actually during that time of labor period in the cycle, there are 3 periods: antenatal, internatal and postnatal period. And if you see that where the deaths are happening most, that is around 46% deaths are happening during the time of internatal period, and another 23% during antenatal period, and also 31% in the postnatal period. So mostly as a clinician and a hardcore clinician, we actually discuss about the facility-based care that is reducing only 46% mortality, but we leave around 31% mortality after delivery and also 23% mortality before delivery that is happening in the community. So these points are very much essential, and I see that PUCSI and BOX and POGS has a potential to intervene here, and it can support the health department to improve the maternal mortality both at the community and facility, and also can link the facility and community link services. So already the previous speakers, Bhaskar Pal and Patel madam, they told about maternal mortality rate. In India, actually that maternal mortality is 97, but in Bihar it is 118. And if you see the graph, we are 6th in the position across the country, but in the absolute number, Bihar is just 3rd after UP and Madhya Pradesh in terms of absolute number. And as per the target, we have a target of 70. Only 8 states they have achieved the stage. And also Sarita Madam was telling about the maternal mortality rate reduction, that our target is 70 by 2030. And the pace of reduction, the current annual reduction rate is very low in Bihar. If we will go on that pace, then it will be very difficult to achieve the target by 2030. So we have to expedite the processes for achieving the maternal mortality below 70. So institutional delivery is increasing in Bihar.
Hello.
As if you compare,
please maintain silence.
Please, if you compare 12 years back, only 14% institutional delivery were happening in Bihar. Now we have reached around 76%. Thanks to all of you, that your continuous support and contribution that helped the Department of Health in improving the institutional delivery. But unfortunately, the institutional delivery, what is happening as per the NFSS data, out of 76%, 57% are happening in the public health facilities, 19% are happening in your hospitals, in private health facilities, and another 24% that is happening in home, and we are unable to touch there. So it is time that if PUCSI and BOX and POX, if they come forward, then we can also cover this 24% of institutional deliveries. But if you will see the regular reporting system on institutional delivery, though institutional delivery, 19% institutional deliveries are happening in the private health facilities, but only 7% rates, deliveries are reported to the health department through MIS system. That means another 11% mortality, institutional deliveries are not reported to health department. Actually, we have to support the health department here to improve the reporting as well. Cesarean section, in the morning, Dr. Patel madam, she was saying that cesarean section was very high in the southern states. And here also you will see in the Bihar, actually the current cesarean section rate is 9.7%. But if you compare to the public health facilities, health department facilities and private facility, there is hell and heaven depends. So in the private health facility it is around 40%, whereas in the public health facility it is only 3.6%. There is a lot of inequalities. So we have to focus here, as madam was saying that in the morning, we have to do the cesarean section audits so that the justified cesarean should be done at the health facilities, specifically in the private health facilities. And also a new program is coming of midwifery. We can also promote this program at our health facilities. So MDSR, maternal death, if you see that as per the current rate of 118, the maternal death in Bihar, around 3,000 deaths are happening every year. So, but unfortunately, the reporting is only 1/3. That means around 1,152 were reported in 2022, and another 1,000 in 2021, and 729 in 2020. So that means only 1/3 of the cases are, maternal deaths are reported by the private facility, government facility, and also the community. But fortunately that we are capturing all the maternal death at the public health facilities, but the challenge is that we are not getting any information from the private facilities and also community. So here the PUCSI's role would be play very critical to improve the reporting situation, and also maternal death audit. Antenatal coverage also Bihar is improving a lot, but you see the 4 ANC, that is actually full ANC, which is required very much, that is only 25% as per NFHS data. So we have to work here, and also the reporting system, because private facilities are not reporting on about the ANC data. Because of that, we are actually facing a lot of challenges at the national level to report our ANC status. Similarly, postnatal coverage after delivery also we are gradually improving. Now currently it is 57.3% in Bihar, for Bihar, but still we have to work a lot with the Foxy and private healthcare providers to improve the reporting and also quality of care. High risk pregnancy tracking and high risk pregnancy management. Actually, Dr. Neelam will be tell detail about this, but I will just tell about that our high risk pregnancy tracking system is very much active in Bihar, and we are regularly reporting around 5% of high risk pregnant mothers in Bihar, and actually we are also linking them to the private and public health facilities through different channels to improve their condition. There are a lot of programs, flagship programs are available at national level, at the state level to improve all these facility and community health services with different line of time. There are a lot of programs were implemented. Just Sarita Madam was discovery about Lakshya and mid NQuas, but there are a lot of programs are available. I will be share the slide. I will not go through the detail about the slides because already 2-3 minutes, 5 minutes we are running late for our session. So there is a very well laid down process for community and facility linkage, but unfortunately there is no link between the public and private health facilities, and also what is happening in the community through the BHS, and also there is no link between the community facility and facility, both private and the public health facility. So for this there are a lot of opportunities and scopes are there how to improve the community and facility linkage. As you know that PMSM program is there, Pradhan Mantri Surakshit Matritva Abhiyan, which was launched in 2016, where actually Foxy played a big role in the around the country to improve the ANC checkup, especially the health facilities. And again, extended PMSM has been launched 2 years back, which has been also supporting to identify high-risk pregnancy mothers and also linking to the health facilities. As you also know that Janani Suraksha Yojana is there, which is an incentivized program where the beneficiaries mothers are getting some financial incentives per care of the mother and baby when they go to the private facilities, and also some private public facilities, and also some private facilities also linked through the Ayushman Bharat to get this incentive. Similarly, JSSK program is also there, Janani Suraksha Shishu Karyakram, where actually we are providing 7 entitlements, where everything is provided free to the mother. It is free diet, free drugs, free service, free cesarean, free diagnostics, free transportation system that is available through 102, 104. So all services are provided free of cost to the mother and the newborn and infant baby. Ayushman Bharat is also a program that has been an ambitious program by the Department of Health, the Prime Minister of
Silence,
India,
please.
where actually we are planning to empanel all the private health facilities. Those were actually providing
Silence,
all,
please.
providing all the services so that our poor mothers can also go to the private health facilities and can avail cesarean section and normal institutional delivery free of cost, and government will be pay the cost. MPCT, sir, that maternal death surveillance response program is also there. Thank you, Foxy, for supporting from the beginning. Here also, if you will support the program, then we can identify what are the gaps at the facility and community level, also the transition level. Then we can act upon that and we can improve all this situation. Suman, just Sarita Madam was saying about the Suman program, where actually we are providing free of services to all the mothers.
Sorry to interrupt you, sir.
Without any financial hardship.
There is continuous murmur from the audience. Please keep silent so that the speaker can, without interruption, the speaker can deliver their lecture. Please.
Thank you, ma'am. So without any financial hardship, with dignity, we are providing services through Suman. Also, I request you, there is a platform called HMS, Health Management Information System, where if you can provide all the data, information reports, so that the government of health can work on this and can improve, and also can link the community people with you and the public health facilities. Also, there are some incentives for the ASAs, especially for mobilization of mothers during the antenatal period, in the postnatal period, for both public and private health facilities to avail services, so that they can also get some incentives for this. So, Suman program already Sarita madam had told, and here also I am just giving that overview of Suman program. So, it is ensuring free service guarantee by the health department with respect to maternity care, and also there is a grievance redressal mechanism for every woman, and also there is a lot of scope for community participation and community mobilization and ownership. Janani Shishu Surakya Karikam, here the free entitlements are there. Everything is free per mother. Free delivery, free cesarean section, free drug and consumers, free diagnostics, free diet, free provision of blood, free transportation system, exemption from all kind of service fees. So this is actually a flagship program for health department. If our private facility also enroll in the Ayushman Bharat, can also provide all these facilities and government will pay to you. So here the coming engagement of private sector, especially the FOXI, the Gynecological Society of Patna and Bihar, your role is coming. As you aware that in 2016, Honorable Prime Minister of India, he requested all the private providers, and during that time FOXI came forward, and FOXI supported a lot to the health department at national level, at the state level. And I thank you, FOXI, for enrolling around 400 volunteers in our system in Bihar. 400 volunteers are still there with us, but unfortunately they were provided services till 2020, and after that this COVID, somewhere we were actually missed between your support and the health department's role in ensuring PMSM at the health facilities. So now I would request the FOXI for all these supports, especially for engagement of private doctors as a volunteer in the PMSMA. Those all 400 already enrolled in the PMSMA, please come forward. Also, as an expert for EMOC services, in the health department, we have a provision that if you, any private provider is coming to health department or public health facility and doing cesarean section, we are providing some incentives to them. Then support towards the key maternal health indicators reporting, especially for ANC reporting, institutional delivery, maternal death, newborn death and immunization reporting. If we are coming forward, then it will be help for strengthening our health system and also addressing the community gaps. Support towards quality certification. Thank you to FOXI, both national and Bihar state team. They are from the beginning, they are continuously supporting us, and today also your FOXI team members are coming regularly to our health facilities for mentoring and monitoring support, and also capacity and hand-holding support. Also support in creating awareness regarding various programs, especially JSSK, JSY, PMSA, Suman, MDSR, PMCT, these programs. So there are a lot of gaps still existing in the community. You see, community care can reduce 15 to 35%, facility care reduce 40 to 60% of maternal mortality, but there another gap is there, 10 to 30%, which can be bridged only through your support. And I could see that FOXI and the local gynecological branches like POX and BOX can support in this to improve the maternal mortality situation of Bihar. Thank you very much for the patience listening.
Very informative talk, and well-being of the women can be improved after comprehensive approach of promoting, preventing, and curative and rehabilitation program. Thank you very much for very information.
Thank you, ma'am.
The next...
Lots of program going on from the government to help or to achieve the maternal mortality at least in 2 digits. Now, hello. Now the third speaker is Dr. Neelam.
Yes. Can I request Dr. Neelam?
She is going to speak on high-risk pregnancy, identification, tracking and management of high-risk pregnancy for improving maternal health outcome. So,
hello.
Dr. Neelam is from our house. She is Vice President presently she is Vice President Menopausal Society Bihar branch and the chairperson of cultural program of this evening.
Thank you. Thank you, chairpersons, for this your kind introduction. Respected chairpersons,
dignitaries of the dais. I can say a lot more, so I won't name them. I am thankful to the Labourcon organizing team for giving me this opportunity to speak before you. I know we are having lots of talk because the topics are very varied and many people are not over here who are in government facilities. So they don't have much concern with these. But actually, if we work together, that is private and government sector, then only we can reduce our maternal mortality. And this is a fact. So please bear with me. Every pregnancy needs special care. All pregnant women should be registered and encouraged for institutional deliveries. What is the importance of antenatal care? We all know that it is a preparation of birth plan and identification of facility for delivery, providing quality care for well-being of pregnant women and fetus, early identification of maternal and fetal complications, and timely referral. This is very important. Identification of a facility for referral. Please always look into it because you have to provide them a suitable facility for their deliveries so that we can improve our maternal mortality. What are high-risk pregnancy? We all know young primees less than 20 years, elderly gravida more than 35 years, severe anemia, hemoglobin less than 7 grams per deciliter, Rh-negative women, twin and multiple pregnancy, malpresentations, antepartum hemorrhage, hypertension, preeclampsia, eclampsia. Previous cesarean, you have been listening to it since morning. Bad obstetric history, history of stillbirth, abortion, congenital malformation, obstructed labor, premature birth, etc. Any bleeding during antenatal period, patient with history of any current systemic illness, past history of illness, HIV positive, syphilis positive, gestational diabetes mellitus, hypothyroidism. So, again coming to Pradhan Mantri Surakshit Matritva Abhiyan, this was fixed days, assured comprehensive quality ANC service to all pregnant women across the country. We all know this, and Dr. Reddy has told this just now. He has reminded us. On 9th of every month, symbolizing 9 months of pregnancy, service package includes special ANC checkups, essential blood investigations and ultrasound. Checkup by OBS-GYN, C-Monk, B-Monk, medical officers and referral to higher facilities if required. Screening for 10 high-risk factors such as severe anemia, hypertension, diabetes mellitus, reactive HIV, syphilis, hypothyroidism, tuberculosis, malaria, previous CS, history of twins or cephalopelvic disproportion. So what is the key features of Pradhan Mantri Surakshit Matritva Abhiyan? That it gives diagnostic services, screening, management of any existing clinical condition, counseling services and proper documentation, birth planning and complication readiness. That's very important. So it focuses on detection of high-risk pregnancies, which gives red stickers, identification, line listing, and follow-up high-risk pregnancies, marking of high-risk pregnancy on MCP card, green stickers for women with no risk factors, and red stickers for women with high-risk pregnancy. But the challenges are that there is low footfall in Pradhan Mantri Surakshit Matritva Abhiyan sessions. Few women come. Low private volunteers participation. So we should ask ourselves to go and volunteer in this. Difficulty in organizing sessions in hard to reach inaccessible areas. Everybody wants to be near his facility or his home, her home, whatever it is. Lack of name-based database tracking and outcome for HRPs in existing Prime Minister Surakshit Matritva Abhiyan portal. And finally, irregular monitoring and follow-up of HRPs in the field. So now comes extended pre-SMA there. And the rationale is that it makes individual HRP tracking. Ashas are not rewarded for mobilizing HRP beneficiaries for follow-up. Perhaps in this they are. Free transport available for beneficiaries shall increase service uptake under Pradhan Mantri Surakshit Matritva Abhiyan sessions. And beneficiary-specific database, tracking and outcomes with a name-based, IT-based infrastructure. So The objective of EPMSMA is to increase antenatal coverage and track all high-risk pregnancy till their delivery to reduce maternal morbidity as well as mortality. And expected outputs are increased in more than 4 antenatal checkups, HRP detection and follow-up, skilled birth attendant deliveries, and institutional deliveries. So the expected final outcome is to reduce maternal mortality. So the salient feature is identification of HRPS, ensuring 3 additional antenatal visits for all HRP by doctors, obstetricians. Next is additional day for PMSMA clinic. This is additional day for PSMA clinic over and above the existing 9th day of every month. So there is one more day, one more opportunity for us to save our mothers. Qualified service providers for PMSMA, mandatory for BMINOC training of medical officers at PHU, PHC, UPHC, UCHC, and deputation of block headquarter OB-GYN doctors to lower level facilities on PMSMA days. And teleconsultation, this has come a long way from PHC to a specialist at a hub. We all need to coordinate it. It cannot go if someone is going right and another person is going to the left. It has to be coordinated. And linking of HRP with designated FRU, so that for institutional deliveries at designated FRU to be facilitated by ASHA. So ASHA has also to be motivated in that. Now, the financial provisions have also been increased, that case-based incentives to ASHA has been given, 100 rupees per HRP for mobilization of high-risk pregnancies for a maximum of 3 follow-up of antenatal visits in the nearest facility for checkup by a doctor or obstetrician, and 500 rupees per high-risk pregnancy on achieving a healthy outcome for both mother and baby, that is 45th day post-delivery after due verification by concerned ANM and MO, so that they can also be a little interested and motivated. Case-based incentive to HRP also, high-risk pregnancy women also, per 100 rupees visit to meet transportation cost for attending maximum of 3 PMSMA sessions at nearest facility for follow-up, antenatal care and checkup by doctors and obstetricians. So the monitoring mechanism, till the time additional features of ePSMA is incorporated in the PSMA portal, the physical mode of reporting and verification of services to be resorted. So these are the columns which have to be filled up in this, and the 3 extra antenatal checkups and healthy outcome of mother and baby has to be written and sent to the MO and by signature of MO and ANM. Monitoring mechanism, indicators to be monitored are percentage of high-risk pregnancy completed 3 additional antenatal checkups, percentage of high-risk pregnancies with satisfactory maternal and infant outcomes after 45 days of birth. That is also very important, because if they are not there, the ASHA is not going to get the money. So supportive supervision mechanism as per the PMSMA quality assurance framework has to be strengthened by quarterly self-assessment of the PSMA SMA facilities, on-site monitoring by District Quality Assurance Committee, and ASHA payment has to be made through Ashwin portal, so that tracking HRP can also be made through Ashwin portal regarding safe delivery outcome. So this has been very much monitored, and it has been made comprehensive. So the way forward is that letter issued for implementation of extended Pradhan Mantri Surakshit Matritva Abhiyan, districts to expedite implementation of extended PMSMA and book expenditure accordingly, orientation and sensitization on ePSMA in a cascade mode for district and block level community mobilizes ASHA, ASHA facilitator and ASHA supervisor, and also medical officers, IEC and BCC for sensitization of the beneficiary, improved HRP identification and tracking, ensuring high-risk pregnant women reporting on PMSMA portal. Thank you. Thank you for your patient listening. And I'm happy to say that I concluded it 2 minutes before time.
Thank you, Neelam, for so much information given by you about the government providing us. But the main aim is to reach the less and less maternal mortality and the fetal mortality.
Yes, the main
progress is to awareness about.
Right.
More is the awareness.
Right.
What are the government going and giving the things? Then about the stress on the ANC, antenatal checkup and follow up till the delivery of the baby and the healthy mother and the healthy baby.
Even 45 days later, not even the healthy delivery, up till 45 days more.
Yes.
That is the important thing.
Thank you. Thank you.
Thank you. Thank you all.
Thank you so much. With that, we conclude the UNICEF session. We would like to get started with the inauguration ceremony. As you can see, our lamp lighting, the lamp is also coming on the stage. Thank you so much, Chairperson, for concluding the session on time. Thank you, ma'am. With that, we would like to call the MOC for the inauguration. Can I request Dr. Nibha Mohan, ma'am, to please do the honors?
Hello. Good morning, everyone, and pranam to all respected seniors. Hope you all are enjoying the scientific session since morning. Now it's time for formal inauguration of our scientific session, the whole scientific program. For this, may I request dignitaries to come on the dais, please. First, may I request Chairperson or organization of this conference, Dr. Alka Pandey, Madam, please come on the dais. Alka Pandey, Madam, have taken lots of efforts to streamline this conference. Aap baithiye tab na bulayenge. Now, may I invite Dr. Shanti Roy, Madam, to come on the dais, please. Padma Shri Dr. Shanti Roy, Madam, she is the senior most member of our society, pillar of our everyone, of all the members of our society. And she is past president of our society and lifetime achiever as well. Now, may I request Dr. Rohana Hatutwa to come on the dais, please. Sir, please come on the dais. Yes, sir has come all the way from Sri Lanka to join our conference. Sir is the Secretary General AOFOG and President CEFOG. Most welcome, sir. Now, may I invite Chairperson, Scientific Program, Dr. Abharani Sinha, to come on the dais, please. And Madam has spent days and nights for few months to make this scientific program the best we tried. Now, may I request Dr. Alka Pandey, Madam, Chairperson of this conference, to have a welcome address, please.
Thank you, Nibha, and good morning, everyone. I welcome you all from the bottom of my heart. And you must be enjoying the scientific session. Welcome, sir. I welcome Dr. S.G. Pai and request him to come to the stage, please. हम बोल दिए सर So, Dr. Abharani Sinha has worked day and night together with Dr. Monica Anand, and they have taken much pains to design this scientific program. She has been coordinating with each and every one of you to make it a great success, and she has done a lot of effort, and I really appreciate her from the bottom of my heart, and her team also. Monica has also worked very hard. And I won't take much of time, and I wish you all a happy learning. Thank you so much.
Thank you so much, Alkadi. Now it's time to present bouquet to our dignitaries. Please come forward, Dr. Amita, Supriya, Monica, and please present bouquet to our dignitaries. To Dr. Alka Pandey, Madam, Dr. our Foxy President, Dr. Rishikesh Pai, sir, to Shanti Roy, Madam, to Rohana, sir, and to Dr. Abharani Sinha. lighting of lamp. So I request dignitaries to please come forward for this event. Light is a symbol of brightness and prosperity as sunlight expels darkness of night. Similarly, blessings bring in our life prosperity and happiness. To make this event a blessed and invoke Goddess Saraswati. Let's join. May I request our organizing secretaries who are present here, Dr. Vinita, please join hand. Dr. Meena Samant, Dr. Pragya, Dr. Amita, please come forward. Thank you, everyone. Now, may I request our Foxy President, Dr. Rishikesh Pai, sir, to give blessings for this our conference to make it more successful.
We have got the evening inauguration anyway, so I would like to thank all of you for coming for this wonderful conference arranged by Dr. Alka Pandey. Please give her a big hand. And all her team, Vinita, all of them. I'll take the names in the evening, so please excuse me at present because I don't have the list, but all of them are my friends and all of you are in my heart. So that's all how it is. Patna is so I know now the hotel also very well because I've come here so many times. So Patna is very important part, Patliputra, it's very important part of our country, our ethos, and our guests have come, Dr. Rohana, Dr. Ratna Siri who is there in the audience, and so many other vice presidents, all of them are there in the audience. I will not take their name, but they are all there in the audience. And these are the 5 conferences. So, there was in the olden days, we had the Foxy main conference of the president. And then at some point in time, the 4 Yuva Foxys were added. And at some point in time, the 5 vice presidential conferences were added. Unfortunately, due to COVID and all other circumstances, in between it was not done, and last year it was started again, but it was a combined conference, and this year we have gone to individual because vice presidents of the federation are like presidents only. It is just that one of us is lucky enough to become president. They all have the same caliber, they are very competent, dedicated, all of them love the organization and they think of the organization all the time and the patient. So all of them are equally, and that's why I wanted this. She is a very important pillar of the organization and this is her conference. And I'm very happy, internally very happy that she is doing this conference, Ankaji, and you have done a great job, and she is the torchbearer. The remaining 4 vice presidents also will have their own conferences, and I'm looking forward to all of them. They are very important, they are like my family. So it's very important to me. Thank you.
Thank you so much, sir.
Most respected President and our guest Dr. Rohana, Dr. Ratnasri, Dr. Mandakini, all my friends and delegates. It is really a pleasure for me to be a person in the organizing this inauguration process of this conference. The scientific program has been worked out very sincerely and with a great effort. Everybody in the scientific team has worked a lot, and I congratulate Abha for making such a program which pleases everybody, which deals with every subject, and which includes one and all. And it is we are fortunate to have our president today here, Dr. Pai, and our guests from Lanka as well as from Nepal. I wish all the success and blessings for the conference.
Thank you so much, madam. Now, may I request Dr. Rohana sir to give his words of blessings for this conference. We are blessed to have you, sir. You joined all the way from Sri Lanka, and we are feeling so elated that our conference is getting more successful. Sir, please give us.
Thank you very much. Good morning to everybody. So I am very happy that we are able to join in this wonderful Labourcon conference, and it has been very well organized by Dr. Alka Pandey and very energetic organizing team. So it is a very timely conference on labour, which we are all concerned these days with, because we are all concerned in reducing our maternal mortality in our countries. So I also like to thank Dr. Rishikesh Pai, actually, who has been very close to both the SAFOG and the AFOG, and after he took presidency, we have had so many programs with FOGSI under his guidance. And also Dr. Madhuri Patel, the Secretary General, has also been very supportive of all these programs. So I am very happy to be representing A4G as the Secretary General and the SAFOG as the President in this very prestigious conference, and to meet every one of you. And it has been a very pleasant moment for us. And along with me is Dr. Ratnasiri, who is the Treasurer of the SAFOG, and also he is the Chairperson of the Maternal and Fetal Medicine Committee of AFOG. So actually SAFOG and AFOG, we are very well interested in conducting programs in our member countries so that we will be able to achieve our target of reducing the maternal mortality. But we are very happy and so delighted that the maternal mortality rate in India is coming down very rapidly. It's something to be proud because when we take other countries, the rates have not come down so much, and it is a concern for the WHO. But here, to see the maternal mortality coming down, it is all because of your efforts. So I thank once again each and every one of you, and wish the Congress all the success. Thank you very much.
Thank you so much, sir. Your good wishes means a lot to us. Now we have an important book release from a senior consultant, Lady Harding Medical College, Dr. Piki Saxena. I'll request dignitaries to join hand for the release of book, please. And Dr. Piki Saxena, you're requested to come on the dais.
Which has been edited by Dr. Piki Saxena and Dr. Hema Divakar, and co-edited by our own Vice President, Dr. Alka Pandey. So it's really a pleasure to release the book on recurrent pregnancy loss. And I request Dr. Rohana sir, Dr. Rishikesh Pai sir, and Dr. Shanti Roy madam to please do the honors. Thank you, sir. आप बीच में आ जाओ, बीच में मैडम इधर किताब को ऐसे
Thank you so much. Now it's time to listen to our chairperson, scientific committee, Dr. Abha Rani Sinha. Madam, please come here and give vote of thanks and your address, whatever you feel like.
Thank you so much, Dr. Nibha. I think it's an honor to be the scientific chairperson for this prestigious Vice President Conference. And for this, from the core of my heart, I thank Dr. Alka Pandey, Chair Organizing Committee, for entrusting me with this huge responsibility. It was a huge, huge task because I wanted to accommodate most of the national faculties, and to some extent we have been able to do it. And we have also brought in international faculties, Dr. Rohan Hatatwa, Dr. Ratnasri, Dr. Ain, and Dr. Asma Rana. And our national faculties, we have our President Foxy leading the team, Dr. Rishikesh Pai, and our Secretary General, Dr. Madhuri Patel, all 4 Vice Presidents, Dr. Alka Pandey, Dr. Asha Bakshi, Dr. Sampath Kumari, and Dr. Gitendra Sharma could not come, could not make it. Dr. Yashodhara Pradeep will be joining us soon. So we are able to bring in 4 sitting vice presidents, and I think most of the other past vice presidents are past vice presidents from East Zone, Dr. Bhaskar Pal, Dr. Anita Singh, and we have other vice presidents. If I start naming them, Dr. Kavita Bapat, Dr. Tushar Kar, Dr. Sadhna Gupta, Dr. Ranjana Khanna, Dr. Sunita Tandulwadkar, and Dr. Sampath Kumari, I forgot to mention your name. You are the sitting vice president. And we have Mandakini Meg Madam. I think, how can I forget her? And we have so many chairpersons, Dr. Mitra Saxena, and Dr. Komal Chauhan, she recently finished her chairperson. Our own Supriya Jaiswal, she's from our place. And we have all our HODs sitting from different medical colleges, Dr. Geeta Sinha from Patna Medical College, Dr. Usha from Nalanda Medical College. So I think it has been a good scientific conglomeration where we have been able to bring in the best of the brains. Kiran Maid, Madam, she is the chairperson of the Violence Against Women, and Preeti Kumar had come yesterday for the workshop. So, and I can find Seema Mehrotra, team of Safe Motherhood Committee. And I think I have so many of them over here. Dr. Binu Kushwaha, she had done a wonderful talk on perimortem CS yesterday. Dr. Piki Saxena, I'm going to moderate a panel on GDM with her. So I think we have tried to bring the best of the faculties, the national faculties, to this place. So now my best wishes for the conference. I think we're going to have a happy learning. And I'll fail if I do not thank our partners, the other organizations like UNICEF, WHO, CARE, JAPAIGO, and Manyata. They all have supported us in abundance. I think this conference would not have been successful without their support. So thank you. Thank you, Team Manyata, JAPAIGO, UNICEF, CARE, and WHO for supporting us. And I also thank our pharma partners who have been with us all these 3 days, the hotel staff, and of course my scientific team, Dr. Nibha Mohan, Dr. Zareen Rahman, and Dr. Monica Anand, and the core organizing team, the 3 dynamic organizing secretaries, Dr. Vinita Singh, Dr. Meena Samant, and Dr. Pragya Mishra Chaudhary, and the joint organizing secretaries, Dr. Amita Sinha, Dr. Supriya Jaiswal, Dr. Charu Modi, and Dr. Ranjana Sinha. I think I should name all of them because this conference has been successful because of the contribution of all of them. And last, I did not mention my mentor, Professor Shanti Roy. I think whatever I do, I have blessings of her. So thank you, madam, for coming here and for inaugurating the workshop. And Dr. Rohana Hatatwa, sir, Ashma Rana, I mentioned her as one of our international delegate. And faculty and madam, I think she has come on my request. She just in one phone call, she said, yes, Abha, I'll come. So where is Dr. Asma Rana, madam? I can't see her. Madam, you please come in front. We are so happy to have you. We have our senior faculties always blessing us. Like Dr. Manju Gita Mishra, I think no conference is there without Dr. Manju Gita Mishra, Dr. Pramila Modi, madam, Dr. Barun Kala Sinha, madam, Dr. Shushma Pandey, madam, and Dr. Dharamshila Sharma Madam, Dr. Rita Sinha, Dr. Rita Jha, and Dr. T. Majumdar Madam, with whom I had worked, I think, around 40 years back. She has come all the way from Kolkata. So Dr. T. Majumdar Madam, I'm really grateful that you have come. So I think I should thank each and every delegate who has come here, because without the presence of delegates and such interactive audience, we can't have a conference. So thank you all. Dr. Bhaskar Par I've already mentioned, he's our dynamic vice president from East Zone. So I think with this I come to the end. I think I should not be miser in thanking people. I want to thank everyone in abundance. So thank you all. Thank you so much.
Thank you so much. So I think with lots of good wishes, the rest part of our scientific program will be more and more and more good, and you'll all enjoy it more. Thank you everyone. That's the end of our inaugural function.
Thank you so much. With that, can I invite the chairpersons for the expert talks? We have Dr. Sushma Pandey, Dr. Rita Sinha, and Dr. Himali H. Sinha to please join us on the stage. Our first speaker is Dr. Mandakini Megh. She is already over here. We would also like to acknowledge we have Dr. Jaideep Tank with us as well. Thank you so much for joining in. With the permissions, can I request all of you to please be seated? The chairpersons, if you can give a go-ahead. Dr. Mandakini Megh is ready.
Very good morning. Very good morning to all of you. And today with us, Dr. Mandakini Megh. She will speak on a very important subject, that is amniotic fluid embolism. And as you know, the amniotic fluid embolism is a very catastrophic complication of pregnancy, and it is due to the anaphylactic syndrome. So I request Dr. Mandakini, please go ahead.
So, good morning everyone. At the outset, I'd like to thank Dr. Alka Pandey and Foxy team, Dr. Rishikesh Pai, Dr. Madhuri Patel, Dr. Abharani Sinha, and all my chairpersons, and most importantly, my senior madam, Dr. Shanti Roy, Manju Gita Mishra, Alka Singh, Abha Singh. I can see all my international faculties. Thank you very much for this invitation. Most importantly, this is my 5th visit to the Bihar and 3rd visit to the Patna. It itself shows that, how much love and affection Patna people have. And most importantly, हम लोग ज्ञान की गंगा के पास में हैं. Because यहाँ नालंदा विश्वविद्यालय, Dr. Rishikesh Pai has mentioned about the Patliputra, and most of the bureaucracy is coming from the, from Bihar. So we are having the land of intellectuals, and I'm very, very proud to be here with all of you, 3rd time in Patna. As Rishikesh has said, even the hotel staff, everybody started knowing us. So thank you very much for that invitation, and thank you organizer for this lovely invitation. I'm going to talk on the amniotic fluid embolism, and this is a favorite quotation of mine. Women are not dying because of a disease we cannot treat. They are dying because societies have yet to make the decision that their life are worth saving. Itself shows that, women, mortality, we have to improve. I think there were many lectures on improving the maternal mortality, and we are not very far behind also. Kerala and Maharashtra has already achieved the SDG goal, and all our leadership is endorsing that we have to bring the maternal mortality very safe. And this amniotic fluid embolism is one of the causes, rupture uterus, PPH, and so many other causes are there. So I'm going to talk on this catastrophic event, that is amniotic fluid embolism. So amniotic fluid embolism is a rare obstetric emergency estimated to occur in 2 to 6 in 1 lakh pregnancy. It usually occurs in the late pregnancy but may occur during the termination of a first and second trimester pregnancy. Also, amniotic fluid embolism is a clinical syndrome of hypoxia, hypotension, coagulopathy. And I think I can see many of the professors, where the high obstetric load is there, you must have come across so many cases of rupture uterus, amniotic fluid embolism, and also other types of traumatic injury which are brought as a referral cases in your hospital. And I also come from the public health hospital background where so many cases we have treated, and also we have exposed to, we have trained our juniors and the junior students to manage these cases. Although the mortality estimates vary widely from 20 to 90%, the syndrome clearly poses a significant risk, and women will die suddenly during the labor. Amniotic fluid embolism is one of the most likely causes. As per the epidemiology, you can see here, maternal mortality approaches around 80%. If there is embolism, there is a mortality. It is a equation. And between 5 to 10% of the maternal mortality in India is because of the amniotic fluid embolism. Also, you can see that the patient with the AFE, 50% die within the first hour. So, as the golden period is there for the PPH, such kind of emergency, the first hour is so much important. First 60 minutes are very important to diagnose and manage the amniotic fluid embolism cases. If the pathophysiology, you can see here, the long-standing term amniotic fluid embolism implies primarily because of the mechanical obstructive disorder as occurs in the thromboembolism. It is the entrance of the amniotic fluid to maternal circulation, as simple as that. But it causes so much, almost, mortality to the patient if not treated in time. So endocervical veins, it goes placental insertion site and site of uterine trauma. The pathophysiology of thromboembolic disease in pregnancy follows the varicose triad of the venous status and the vascular injury and the hypercoagulable state. So these are the three things, mainly of the venous stasis, vascular injuries, and the venous stasis is present in pregnancy secondary to the progesterone mediated. We all know there is a venous stasis in the second trimester onwards. So the pathogenesis will be, it will be open venous channels in the uterus. After that, the amniotic fluid, fetal debris, antigen enters into the circulation. After that, prodromal stage, that is nausea, vomiting, tachypnea and chills are there. Acute hypoxia and pulmonary hypertension is there. And it may lead to the acute left ventricular failure and later on the fetal edema. So, these events goes in succession very rapidly within 60 minutes, and you just come across a patient who is already in shock. A vascular injury can be present in pregnancy as a result of the increased cytokines and also injury to the vascular endothelium. So pregnancy itself is a hypercoagulable state because of the increase in the procoagulation factors. To emphasize the clinical findings secondary to the biochemical mediators, we have to see that the clinical syndrome of the, this is also known as the anaphylactide, as mentioned by Dr. Sushma Madam, anaphylactide syndrome of pregnancy. There is anaphylaxis in the pregnancy. And there are a lot of pathological reaction at micro level, and amniotic fluid and fetal cell enter the maternal circulation possibly by triggering an anaphylactic reaction which is to the fetal cells, debris, etc. So what are the risk factors? Risk factors are cesarean sections, advanced maternal age, multifetal pregnancies, abruptio placenta, abdominal trauma, then the placenta previa, uterine rupture already mentioned, cervical lacerations, forceps delivery, and the polyhydramnias. So these are the risk factors. It is also known as anaphylactic syndrome in the pregnancy because of the exposure of the maternal circulation to the amniotic fluid, fetal cells, debris, etc., leading to hypoxia and the vasospasm and cardiac failure, which may result in activation of the complement cascade, stimulating the endogenous chemical reactions and leading to the anaphylaxis. We can divide this syndrome into two. One may be the phase 1 and one may be the phase 2. In the phase 1, there is biochemical release after the entry of the amniotic material, and which leads to the, after the pulmonary vasospasm, pulmonary hypertension, and increase in the right ventricular pressures. Also in the phase 2, it leads again to the left ventricular failure, which is very, very serious. And also the biochemical mediator led to the DIC. And once the DIC sets in, we all of us know it's so difficult to handle the patient. Now the signs and symptoms. If patient is going on everywhere, we go to the labor room, sab theek chal raha hai, everything is very nice, and suddenly you get a call that is a sudden cardiac arrest, patient is tachycardia, tachypnea, hypotension, and then you are in a, this thing that you have to call so many juniors, they have to call the seniors, and they have to manage the patient, and also do the differential diagnosis. That is very, very important. Then respiratory failure with significant cyanosis, hypoxia, pulmonary crackles, and quickly follows. Also the coagulopathy, when once it is sets in, then start the bleeding from all the, venisections and other PPAs and other thing. Also the uterine hypotension also starts. So clinical abruption, the abrupt onset of the dyspnea, cyanosis, hypotension, coma, all these in quick succession. And also pulmonary edema, coagulopathy, mild in almost every case is present. The evidence of, this CNS involvement, hypoxia is present, and also in the mental state progressing to coma. And also there is a abruptio, fetal demise, and the hemodynamic profile is to be seen. What is the differential diagnosis? You are in labor room and suddenly tachycardia, everything starts. We have to have very vigilance while diagnosing proper amniotic fluid embolism to be separated from the rupture uterus, acute hemorrhage, placental abruption, uterine atony, eclampsia, peripartum, cardiomyopathy, etc. Everything should, come to your mind before making the final diagnosis of the amniotic fluid embolism. There are anesthetic causes also, that is high spinal anesthesia, aspiration, local anesthetic activity also. And there are many non-obstetrical causes, that is pulmonary embolism, air embolism, anaphylaxis, sepsis, all these are the non-obstetrical causes. We have to do a lot of laboratory investigation, but in a very quick succession. So in non-specific all blood counts, coagulopathy, investigations, X-ray chase, some also advise a CT, and also the echocardiogram. Pulse oximetry has to be ordered, prothrombin time, partial thromboplastin time, blood type, creatinine, electrolytes, X-ray, all this has to be immediately investigated and sent for. Also the arterial blood gases levels also is expected to be changes and consistent with the hypoxia. So management, amniotic fluid embolism is a diagnosis of exclusion. We have to exclude and then treat. Management is a symptomatic and supportive, and targets are to maintain the oxygenation, hemodynamic support and correction. And this is all critical care, and we are very lucky to have now SDU, critical units in the obstetric wards itself. I think Bihar also must be having a lot of critical, ICUs and SDU, etc. So this is a management that oxygenation has to be maintained, circulation has to be established, and coagulopathy has to be arrested with all these, factors. Airway breathing, administer 100% oxygen via the reservoir face masks. Then prompt assessment by control airway and ventilation. Circulation by big, large bowel lines. These are all ICU managements. Left lateral tilt by the manual or uterine displacement, and hemodynamic support would be included with the preload optimization, vasopressor. Fluid resuscitation, crystalloids, infusion of inotropy may be required to maintain the mean arterial blood pressure. An arterial line for the continuous blood pressure monitoring is a must. Uterine tone has to be maintained with oxytocin, ergometry, prostaglandins, coagulation by, cryoprecipitates, platelets, FFP, all these once the coagulation sets in. Antifibrinolytics and the amniotropic should be maintained and should be given, may be helpful in the evidence in like. Now, intensive care monitoring is a must, and as the patient is in high risk of developing the ARDS, heart failure, and DIC. Supported treatment, of course, we have already started, ventilation and hematological support. Potential intervention, most important, may be inhaled nitrous oxide for the nitric oxide for the pulmonary hypertension may be thought of, and ECMO for the severe hypoxia and left heart failure may be started. So there are various guidelines, studies, 1 minute, just last. So amniotic fluid embolism, there are recommendations, SMFF recommendation which gives, only 1 minute please, that laboring, if there is any sudden collapse, you must think about the amniotic fluid embolism. These are the recommendations. And in conclusion, I'd like to say that early diagnosis of the amniotic fluid embolism is the key. Prompt management is very essential and mandatory, and also the disorder is not a mechanical embolic phenomena, but probably biochemical response. And mortality is very high, so you have to take a, lightning decision to save the patient from the embolism. And in future, there is lot of score for the research, and we have to do the research on histamine, prostaglandins, all these, lot has to be done in the area of the this amniotic fluid embolism. And we celebrate or we focus on the amniotic fluid embolism awareness day on the March 27. And thank you very much for the patient listening. And last but not the least, I am contesting for the post of President Foxy. I know Bihar loves me, and I also love Bihar. Tushar, don't smile.
Thank you so much, ma'am. But
thank you very
we
much.
would like
I know
to now.
you are going to support me. अरे बोलने दो यार.
अरे लेकिन वो टाइम खत्म नहीं होता तो मैं आपको बोलने देता. Please.
Thank you very much, Dr. Mandakini, for the very nice presentation, and my all the best wishes for your president candidature. Thank you so much.
Thank you, ma'am, for your wonderful presentation. You have completed all the aspect of this amniotic fluid embolism. What happens in our hospital? Our patient become gasping, and there is frothing from the mouth, and when his patient died, then we say that patient has died due to the embolism, because the postmortem is not doing in each and every case. Thank you. Now I welcome Professor Tushar Kar, who will speak.
Dr. Tushar says वैसे CV पढ़ने की जरूरत नहीं है, सिर्फ support करो. Am I right, sir?
Yeah.
हाँ, थोड़ा सा can we get started to keep it on time? That's all. So yes.
Respected chairpersons, madam, revered teachers of teachers, teachers, postgraduates, and members of the BOGS, and esteemed national, international speakers or faculties. At the outset, I must thank and congratulate our senior people like Manjugita ma'am, Santi ma'am. So all these people like Foxy President Rishikesh, my close friend, Alka madam, our Vice President of East Zone, and all the members, especially you see the organizing scientific committee chairpersons. This is here very much, and I must give you thanks at the outset. And all the like Vinita ma'am, any are there, Meena is there, Pragya are there, all are close to my family members. Bihari is next to me. Within last 6 months, I have come 4th time to this place. And you see how she has given me this topic. I'll tell you that greetings and blessings from land of Jagannath. So perhaps she has given me this topic with an expertise of 39 years of experience or of clinical practice. Perhaps that's why she has selected this topic to me, that is sudden maternal collapse. It is told by Henry Ford that anyone who stops learning is old, whether at 20 or 80. But anyone who keeps learning stays young, like you, Manjugita ma'am, like Santi ma'am, so senior people are, Charu ma'am, so senior people are here to learn this subject. But you see, before that I must tell why I selected, and they have selected perhaps, of these things, that is lady, lock and labor. Then I thought, in which I will present. Let me come with my own evidence, my own clinical practice. So to start with, this is the first case. I made this case a lady doctor 25 years back. I did a cesarean section. Immediately after 1 hour of cesarean section, she was in the labor room for observation. My resident, they told that, sir, she is having dyspnea and chest pain. Then I immediately rushed. There was hypotension, there was tachycardia. Then I resuscitated the patient with oxygen and everything, hydrocortisone, whatever so needed. But you will be astonished to know I gave a cardiac call. The cardiologist on duty was my friend lecturer, Dr. Raut Rai. He could not come, not traceable. Then I remember those days to 97. I raced to his house, jumped up the wall and bring him, and only he added, you see, plasma thinner like heparin. And I am giving what could be the diagnosis to all the audience, the first case. Now let's go to the second case. I was on duty, RS duty, in the year 23 years back. And Professor P.C. Mahapatra was assistant professor on call. Then this patient had come and delivered immediately in the second stage, and suddenly she was rigor and chill and suddenly collapsed. I called him. He saw the patient was living in front of him, both of us. She died. Then within 24 hours, 3 maternal sudden death occurred like this. One was post-cesarean in the ward, high-risk ward. The another ward in first stage of labor. So what happens with this? I am giving the clue to you. We sent for post-mortem autopsy. We sent the viscera for the state forensic laboratory for the examination. Then we didn't leave all the drugs which were used, including saline, sent to Kolkata CDL, Central Drug Laboratory. It came 2 years for the examination to come. Again, I am giving the question to you. What could be the diagnosis to the audience? At the end of my presentation, we will know this. Let's come to the third case. On Thursday, 2 days back, this came. Day before yesterday, this came. She was a para 4, delivered normally. After 2 hours of delivery, she had 4 times convulsion with normal BP. Now she presented to me in my labor room, SV Medical College, Cuttack, with 30% saturation. She was resuscitated, intubated. She was sent to central ICU. I went there and I saw that BP has gone to 143/113. Now pressure amends were there. But again, it's a case of type 2 diabetes mellitus with 375 milligram. That is the only thing. So dear audience, dear clinician, you think of whether due to type 2 diabetes or whether due to something else. Again, I'll be discussing at the end of the talk. So with this, maternal collapse is a rare but life-threatening event with wide-ranging etiology. The outcome primarily for the mother but for the fetus depends on prompt and effective resuscitation. So therefore, feto-maternal resuscitation is quite urgent. And what is the definition? As an acute event involving the cardiorespiratory system and or brain, resulting in a reduced or absent conscience level and potentially death. Potentially death, remember friends, at any stage of pregnancy and up to 6 weeks after delivery. So we asked to the postgraduate after 7 days or 6 weeks, it is up to 6 weeks. Then the incidence of maternal collapse or severe maternal morbidity is unknown, as morbidity data are not routinely collected, especially in India. A woman is defined as having had a severe maternal morbidity event if there is a risk of maternal death without timely intervention. That means timely intervention is required. Now, as such, it is a rare event with potentially devastating consequences like maternal death. It is essentially that caregivers are skilled in initial effective resuscitation techniques like us. We must resuscitate at least to some extent. They let the patient live. So there the concept of maternal near miss came. Now, and are able to investigate and diagnose the cause of the collapse to allow appropriate directed continuity management. Unless I give the resuscitative measure, the multidisciplinary approach cannot come. If I do not attend in time, doctor do not resuscitate immediately, emergency, the patient cannot live for 15 minutes. The other people cannot approach. The patient cannot be brought to the CICU. So unfortunately, In reports regarding morbidity in the CMAC report, areas of substandard care to be identified, like in our centers, including poor resuscitation skills, because many of us are not well versed with these skills. But it should also be remembered that death and disability may result despite excellent care. So we must counsel patient. You just call the attendant, see this patient, we are trying, the patient may die. So the data from UK obstetric surveillance system, that is ECOS, showed a severe maternal morbidity rate of 6 per 1,000, that is 600 per 1 lakh maternity. So therefore, friends, it's a quite good incidence. In the last triennium, in the UK, the maternal mortality rate was 14 per 1 lakh. But again, not all maternal deaths are preceded by maternal collapse. Thus, the true rate of maternal collapse lies somewhere between 0.14 and 6 per 1,000. That is 14 to 600 per 1 live birth. So, can women at risk of impending collapse be identified early? If it can be identified early, perhaps the address can be there. Now, it should be noted that vasovagal attacks and the postical state following an epileptic seizure are the most common causes of maternal collapse. Friends, so therefore, any convulsion or an epileptic seizure due to anything, may it be vasovagal, or it will be amniotic fluid embolism, or eclampsia, or a hypotension due to PPH or something. So these are the causes. The third case, which 2 days back has come with convulsion, it may be due to hyperglycemic, it may be due to eclamptic seizures, or it may be due to vasovagal. So it used to be the commonest cause is the convulsion. Now, an obstetric early warning score chart should be used routinely for all women to allow early recognition of the woman who is becoming critically ill. So antenatal care for women with significant medical conditions at risk of maternal collapse, like diabetes mellitus in the third case, should include multidisciplinary team approach with a pregnancy and delivery management plan in the place. Now, therefore, the first early warning scoring, that is EWS systems, were introduced on the basis that a deterioration in simple physiological vital signs will precede significant clinical deterioration, and that early intervention will reduce morbidity. So therefore, friends, we must depend on the, at this stage, early warning scoring system. That system will provide, if deteriorates at the early, that means identification at the earliest features of the coming down can be a great help. Now, despite this EW system have been demonstrated to be highly effective, even when their use has triggered input from a specialized medical emergency team, and although their use is recommended by the National Institute, that is NICE guideline, this is based on informal consensus rather than the evidence. So therefore, don't believe 100% with the EWS. So the common reversible causes of collapse in any woman can be remembered using well-known aid memory. What is that? Employed by the Resuscitation Council UK, that is RCOG, that 4T and 4H. Let's see what are those. So what are the causes of maternal collapse? So you know, hemorrhage is the commonest condition. That major obstetric hemorrhage has an estimated incidence of 3.7 per 1,000. In India also, it is the commonest cause. Out of the commonest hemorrhage cause, postpartum hemorrhage, major antepartum hemorrhage, and ectopic pregnancy. Now, PPH in shock with this pneumatic anti-shock garment, you see many of us are using, and this is one of the cases. Again, last week, we survived a patient because of the PPH using this suddenly, and in the periphery also, in Bihar, Odisha, Eastern India especially, where, and you will be astonished now today, the maternal mortality, there is a shift of paradigm of the causes. Earlier it was hemorrhage, now it is hypertension disorder pregnancy in Bihar, Odisha, Jharkhand, Northeast. So that is the change, because we address the hemorrhage at the early stage. So therefore, another condition is a concealed hemorrhage. So you can see that abortion with a concealed hemorrhage with BP 80/50 with SpO2 2 to 76%, and 3 months back this case had come, and we could revive that patient. Now other rare causes like splenic artery rupture and hepatic rupture, these are very rare causes of the PPH or the hemorrhage. Now amniotic fluid embolism, Mandakini Ma'am has covered very nicely. So lies somewhere between 1.25 to 12.5 per lakh. Now here, that is features of the acute hypotension they will present, BP will fall down, respiratory distress, and acute hypoxia. So 3 features, friend. You ask me that the patient, the first patient, there was dyspnea, chest discomfort, and seeing the blood pressure is 80/50, that lady doctor, and pulse rate was 142, and feeble pulse I could see it. So I gave the pressuramine, I gave the hydrocortisone, proper position, oxygenation. So with this resuscitated, then later on it was added with heparin. Now primipara immediate post-cesarean, this is the, what could be the diagnosis? Perhaps I was asking the audience, what is the diagnosis? Perhaps the thromboembolism in a post-cesarean immediate after 2 hours, that could be the cause, but the patient could be survived. Now here, this often results in left ventricular dysfunction failure develops later on, so to take care of the LVH. Now cardiac causes, as you know, the most common overall causes of maternal death. The majority of deaths secondary to cardiac causes earlier in women with no previous history. The incidence of primary cardiac arrest in pregnancy is much rare. It is around 1 in 30,000 only. Now the main cardiac causes of death are myocardial infarction.